cataract surgery 2 years ago in the right eye at a different center. Now he is unable to produce operative documents for the same. After surgery, the vision improved, but over the past 1 year, he noticed gradual painless blurring of vision in the same eye. No history of redness, trauma to the eye, and there is no complaints of floaters and flashes. Patient has been diagnosed with hypertension 2 years back and now is well controlled on antihypertensives. There is no significant family history. There is a history of smoking, 15 pack years. On general examination, patient is alert, conscious, cooperative, and the blood pressure, pulse, and systemic examination is within normal limit. On ocular examination, best corrected visual acuity is 6/60 in the right eye with -2 diopter spherical lenses and 6/24 with -2.5 diopter spherical lenses in the left eye. The pupil is round, reactive to light, and extraocular movement is full and free in both the eyes, and there is no REPD. On slit lamp examination, the anterior segment is within normal limit as shown in the table. The lens in the right eye is pseudophakic and the PCR IOL is in situ with posterior capsular opacification, while in the left there is advanced immature senile cataract as shown in the diagram above. The retrolental area is within normal limit. The optic disc in both the eyes is medium in size and round in shape with well-defined margins. Cup disc ratio is 0.5 and 0.7 in both the eyes respectively. There is thinning of neuroretinal rim. As shown in the Amsler-Dubois chart in the right side, there is in the right eye the foveal reflex is absent and the greenish membrane is present over the macula with overlying hemorrhages. There is drusen, 2 disc diopter inferior to the optic disc and 1 disc diopter nasal to the optic disc. The peripheral retina is flat and attached. In the left eye, the fundal reflex is dull with retinal pigment epithelial changes and the periphery couldn't be seen due to opacification of the lens. Investigations, gonioscopy. In gonioscopy, Schaffer's grade 3 open angle is found and the intraocular pressure is 22 mm of mercury and 26 in both the eyes. The blood investigations of blood sugar, urea, creatinine and lipid profile are normal and the patient is deemed fit for ocular investigations by cardiology. On retinal imaging, the optical coherence tomography for macula as shown confirms choroidal neovascularization in the right eye with central macular thickness of 292 micron and the OCT RNFL of both the eyes as in the figure to the right shows retinal thinning. Provisional diagnosis and active choroidal neovascularization secondary to age-related macular degeneration associated with open-angle glaucomatous changes in a pseudophakic eye of a 68-year-old hypertensive patient. And anti-glaucoma medications are to be started with and IOP monitoring to be done monthly and then treatment modified accordingly. In the right eye, plan for injection intravitreal ranibizumab for active CNVM and topical steroids post-operatively. Follow up with BCVA and OCT macula to assess response and further treatment. YAG laser capsulotomy to treat PCO will be done later on. In the left eye, cataract surgery for after stabilization of right eye is planned and post-surgery glaucoma workup using OCT, RNFL and HFA is done. Strict control of systemic hypertension and patient is to be counseled for further follow-ups. Thank you.
Any questions? Yes, sir.
Is there any role of since you are seeing a patient with glaucoma also, would you like to do a CCT in this patient?
Yes, sir, we would do. But I was thinking of planning the HFA and CCT after cataract has been removed and then treating the glaucoma.
No, if suppose the CCT is let's say 480 and you have seen your IOP has come down to 20. So then what would you do?
Then we would stop the decrease the dose of glaucoma medication and treat accordingly because.
I mean, I'm saying the CCT is very thin. The cornea is very thin.
Okay.
And
there is wrong measurement of IOP then intraocular pressure then.
So what should be the IOP then, and what would you think it would be?
So it would be on the high. It would be higher than what it has come in the.
Yeah, you can open your mobile and see the Google, CCT corrected IOP and you'll get the whole table. Yes. And with a CCT of 480, it will be, the correction factor will be around 4 to 6, if I'm not wrong.
Millimeters of mercury.
Yeah.
Correct. Any other questions? You have to ask a question. Yeah, otherwise we will question you. Give the mic to. Just because you were a PG before 2 years, it does not mean you should not ask questions. You ask. Keluga. And one more thing, ma. You are talking about age-related macular degeneration. Of late, people are talking about glutathione, citicoline, somazina, antioxidants, etc., along with methylcobalamin. Is there any beneficial effect in giving all these expensive supplements, or are we producing costly urine?
Sir, according to ARMS 2, it has been seen that antioxidants work in dry ARMD and in neovascular.
What is the difference between dry ARMD and wet ARMD?
So, sir, in dry ARMD, there are drusen's in the below the retinal pigment epithelium, while in the wet ARMD, there is blood vessels from the choroid which enter into the between the
retinal pigment epithelial cap junctions,
yeah. And there is
edema.
bleeding.
That is why it is wet. If there is edema between the retinal pigment epithelium and the adjacent layers, it is wet. If there is no edema, it is dry. Okay, you said there will be drusen. What is the chemical composition of the drusen?
So, drusen's are lipofuscin and phagolysosomes which are not which are present in the RP.
Where do they come from? If something is inside, it should have come from somewhere. Where has it come from?
RP cells are function is to destroy the cones and rod cell disc.
What? It will destroy the cones and rods?
It will engulf them and they enter into the RP.
Have you heard of apoptosis?
Yes, sir.
And of cell degeneration products?
Yes, sir.
Yes. Very good. Okay, ma. Any other questions from the audience?
Any role of anti-VEGF in dry age? Is there
Any role of, sir?
anti-VEGF?
Anti-VEGF. Ranibizumab, bevacizumab, monoclonal antibodies.
Sir, in advanced dry AMD, where there is neovascularization, in that case, there is. Otherwise,
It is not. In wet AMD only the indication is there. In wet AMD, the role of anti-VEGF is there.
yes, sir, when neovascularization.
Otherwise, yes.
Would you give photodynamic therapy a chance?
Yes, sir. In wet AMD, yes, sir. Photodynamic therapy is yet another way out for treating the same.
Why didn't you mention it in your presentation?
Sir, actually, in our hospital, usually
Nobody has photodynamic therapy in any hospital, ma. It is there in the textbook. You should mention it.
Okay, sir. I will from the next.
Okay. Right. On that note, what do you say, sir? Leave her alone. Okay. Good. Okay, ma. Congratulations. Good round of applause for this girl. Thank you.
I would like to ask Dr. Ayan Bhattacharya for the next presentation.
So the speaker is Ayan Bhattacharya ji. Okay.
Good morning to one and all present here. I am Dr. Ayan Bhattacharya, second year PGT of RG Medical College. And today I will be presenting a case of choroidal metastasis with exudative retinal detachment. A 72-year-old male patient came to our OPD from the Department of Radiotherapy. He complained of blurring of vision since the last 3 months with floaters and ocular pain for the last 3 weeks. He was a known case of moderate diffuse adenocarcinoma of esophagus with liver metastasis and was currently under treatment. Patient was free of any ocular symptoms 3 months back. He complained of gradual onset painless progressive diminution of vision for the past 3 months along with ocular pain floaters for the last 3 weeks. Past medical history showed that he had loss of appetite, weight loss, abdominal pain, hoarseness of voice, along with difficulty in swallowing both liquid and solid food for the past 10 months. And he was subsequently diagnosed as a patient of adenocarcinoma of esophagus along with liver mets. He had a history of both eye cataract surgery, no significant family history, and was a chronic smoker. In general examination, patient was poorly built, cachectic. Patient was conscious, cooperative, and oriented with time, place, and person. His vitals were otherwise normal, other than the slightly raised temperature. Cystic examination was perfectly normal, but there was a tenderness noted in the right hypochondriac region. Ocular examination. The right eye showed a best-corrected visual acuity of 6/60, which was not improving with glasses. And the left eye showed a vision of 6/6 with a -1 diopter spherical and -0.25 diopter cylindrical power. There was a RAPD present in the right eye. The IOP of the right eye was 10 mm and the left eye was 16. Extraocular muscle movements were full and free. Slit line examination of eyelid, adnexa, conjunctiva sclera, cornea, anterior chamber, and lens revealed no significant abnormalities. On the fundus imaging, a large elevated yellow colored lesion was noticed superiorly and superiotemporally to the disc, along with a bullous retinal detachment noted inferiorly. The left eye fundus was within normal limits. So this is the fundus image of the patient showing an elevated lesion superior to the disc with a bullous retinal detachment. The USG shows a choroidal mass with retinal detachment. The OCT shows a lumpy appearance of the RP of the choroid with subretinal fluid. So this is the case summary. This appears to be a case of unilateral choroidal metastasis with exudative retinal detachment in a 72-year-old male. So patient was already on combined chemo and radiotherapy for multi-system involvement. And patient was advised to continue the same from ophthalmological point of view. So early ocular examination could have significantly contributed to the preservation of vision. Prompt diagnosis might have averted the progression to retinal detachment, and hence a routine ocular examination should be advocated in all patients with carcinoma to facilitate timely detection and intervention. Thank you.
Wonderful talk. What is the embryological origin of the choroid?
Sir, it is from mesodermal in
Mesenchyme.
mesenchymal in
Mesenchyme proximal to the optic disc cup. Okay. What is the embryology of the esophagus?
Sir, esophagus is mesodermal in origin.
Esophagus is from the endoderm. It has a myenteric complex which is from the mesoderm. Okay. Breast cancer. You spoke about breast cancer?
No, sir.
Breast cancer is one of the commonest carcinomas which can have metastasis in the choroid. Once again, what is the embryology of the breast tissue? You are all studying MS. Isn't there a chapter called embryology in anatomy of the eye?
Yes, sir.
Poor Professor A.K. Khurana has written extensively about it. Why didn't you read chapter 2 in Professor Khurana's textbook? Do you read Khurana?
Yes, sir. Yes, sir.
Good. Please read from first page to last page. All right. The reason for my asking such embryological questions is because metastasis usually is along the old embryological lines. A carcinoma occurring in a mesodermal organ will more likely metastase to a mesodermal originated organ. Why can't it come to the tumor this tumor metastasis you are talking about, why doesn't it occur in the retina or in the cornea? That is also in the eye only. The cornea is well supplied with vasculature. Why doesn't this metastasis occur there? Why does it have to go to the choroid? Carcinomas usually migrate towards their original embryological origin. Have you read about the dermatome?
Yes, sir.
What is a dermatome?
The parts of the body is having this.
How many dermatomes does a human being have? I am being very cruel. And there are people looking at me with vengeful eyes. You step out of the building, we will take care of you. Huh? You step out of the building, we are 10 PGs. You fellow coming from Velur are making our life miserable. Anyways, doctor, this is just to throw some light on the fact that embryological origins also matter in metastasis. That is the single take-home message I want to give to all of you. Okay, okay. You were talking about radiotherapy.
Yes, sir.
What is the favored chemotherapeutic agent you will use?
Sir, chemotherapy agent that was being used was paclitaxel.
Paclitaxel. Wonderful. Very good.
Yes.
And
And this was being continued. We can also think about epirubicin group of
doxorubicin, epirubicin.
Doxorubicin.
No, no, no. Have you heard of something which is related to a precious metal?
cisplatin.
Cisplatin. Cisplatin. And one more thing. How is the dosage calculated in chemotherapy?
Sir, according to body weight.
No. According to surface area. Cisplatin is 75 milligrams per square meter of the surface area of the patient. Just wanted to give this as a take-home message. Some dosages are calculated on per kg body weight, but in carcinomas generally it is calculated on the basis of the surface area. I really do not know how they measure the surface area of an obese individual and a thin individual, but that is how it is calculated. Anyway, Dr. Ayan, good topic, tough topic. I really would like to appreciate, because you could have spoken about some common syndrome, made a presentation and walked away with 5,000 rupees. But you chose a deliberately tough topic, like metastasis to the choroid, which deserves appreciation, and we want to congratulate you for that. Because we have given 25 marks for originality of the topic. So on that front, among all the topics presented until now, your topic and that IOL opacification are original out of the blue topics. So we would like to congratulate you as well as Dr. Shaun for bringing out a different topic. Congratulations. I am not actually as bad as you think I am. Yeah. Thank you.
But how did you did you follow up the case? What happened next?
So that actually the patient was given a life expectancy of 21 months. So
nothing was done from the ophthalmological part?
Nothing else could be done, sir. From the palliative treatment was being given, and
from the eye department, nothing was done?
Nothing else. We counseled the patient, and everything the family members knew about it and didn't want to share it exactly with the patient, all the prognosis.
You mean the patient never knew he had cancer?
No, he knew he had cancer, but he didn't know that he had 21 months to live.
Thank you, doctor.
Wonderful presentation by Dr. Oyon. Now I would like to ask Dr. Divya Jain to come up.
Good morning, everyone. I am presenting a case of Stargardt's disease. We had this patient, 47-year-old male, with gradual onset, painless progressive loss of vision since 1 year, with color vision abnormalities, which is not associated with any pain, redness, and photophobia. There is no history of similar complaint in the family, and patient is non-smoker. On examination, general physical examination, vitals, and systemic examination was within normal limits. On ocular examination, best corrected visual acuity of both the eyes was 6/60 with accurate PR. Pupils were regular reactive to light, IOP, extraocular movements, eyelid adenexa, conjunctiva, sclera, lens, and anterior chamber examination was unremarkable. On fundal examination, optic disc of both the eyes was within normal limit, and macula of both the eyes showed dull foveal reflex with yellowish white dot surrounding hyperpigmented area confined to macula. On further investigations, fundus photograph showed paramacular yellowish flecks with central macular atrophy. On OCT, it showed loss of inner and outer photoreceptor layers, along with thinning and destruction of RP. And fundus fluorescein angiography demonstrates a silent choroid and a ring of hyperfluorescence. The most probable diagnosis is atypical presentation of Stargardt's disease, which is late onset. No active intervention was suggested to the patient, and long-term follow-up was advised. Further discussion. SGTD1 is a SGTD1 clinical spectrum varies widely. Age of onset could be indicative of disease severity, with earlier onset being associated with more aggressive course of disease. Adult onset SGTD1 is generally associated with missense mutation and better prognosis, while childhood onset is largely linked to null variants with poorest prognosis. Causes of very late onset disease after 6 decades are extremely rare. There is no approved treatment for Stargardt's dystrophy. Different therapies are under investigation. The most promising are visual cycle modulators, complement inhibitors, gene therapy, and stem cell therapy. Thank you.
Don't mistake me. What is the intention of your presentation?
So this was an atypical case of Stargardt's. Stargardt's usually happens in juvenile, but this patient came with a late onset. It was...
was it a late onset or a late presentation?
Probably it was late onset. The patient said that he had no difficulty in vision, and then later on this thing happened.
Amma, use the mic.
What's the normal age of presentation of Stargardt's disease?
It's juvenile adolescent between 10 to 20 years of age. These present. Matlab, it can be in like 5 years also. Matlab, it's young disease.
Histopathologically,
Yes, sir.
what is the chemical which is deposited?
Lipofusion, sir.
Where does that come from?
Sir, it comes from, there is this gene that encodes for ATP binding cassette. Like
Cassette protein.
Yes.
RMP. Very good.
Yes,
That is
sir.
the correct answer.
So there is this mutation in that gene that leads to deposition of this protein.
And what happens because of the deposition of the protein?
There is this retinal pigment layer atrophy. There is this atrophy in the outer photoreceptor layers.
Correct. Which cells are affected?
RPE cells are affected
Yes, and
primarily.
then?
And then so photoreceptor cells, rods and cones, they are affected.
Rods or cones? Which one first?
Sir, cones first and then rods.
Exactly. Very good.
Yes, sir.
So that is why color vision is first affected and then actual vision is affected. Okay. What is the role of VEP?
Visual evoked potential in this case.
ERG?
Yes, sir. In this ERG, Stargardt's is actually divided into 3 stages on the basis of ERG. Like in stage
Good.
1, there is this normal ERG, and then stage 2, there is this more of cone, and then the ratios are distorted.
In which case you will go for VEP. What will you observe in the VEP before you observe something in the ERG? Professor Parvez Alam, you have to ensure my security from PGs and put me on the flight today in Calcutta. Yeah.
I think everybody will
Enjoy beating me?
I think from here the PG, not only PGTs, rather we will be also going and motivated by your all depth of knowledge. That is extremely
No, I just wanted personal security from you.
very broad idea and study. When I feel that most of the questions he is asking, sir is asking, I am unable to find the right answer. So it's a great year, and the aim of this competition and year is to motivate people, because throughout our life we have to be motivated. There is no end, and those who are more motivated, they will be doing far better for our patients, which is the aim of everyone.
Anyways, thank you, doctor.
Thank you.
Any other questions for this?
So
girl or
don't
shall-
worry about that.
Don't worry.
Even they will be protecting you.
Actually, these questions will also help you when you give your final PG exam. These are the questions that will be asked in your Viva. So one thing, which gene is responsible for Stargardt's?
ABCA4.
And what is it responsible for?
ATP binding cassette protein. Matlab it's basically responsible for clearing the debris of RP cells, and
Vitamin A,
like vitamin A clearance,
clearance or production?
protection.
What is Wald's visual cycle? Anyways, I don't want to take too much of your time. There are other PGs also. Brilliant question. Professor, what's your name? Good question. He asked a very good question. That is from the textbook of biochemistry. It is published in the Aravind Eye Hospital textbook of biochemistry. Wonderful question. You read that book? Have you read that book? Aravind Eye Hospital comes out with textbooks. Anatomy, physiology, biochemistry, microbiology, ocular pathology, etc. This particular question, he asked about the gene, its manifestation and its biochemical action is explained in the textbook of biochemistry published by Aravind Eye Hospital. Wonderful. There is one doctor in Bengal, his name is Dr. Asim from Katwa. Do you know him? Yes. Asim. I like him a lot because he read the textbook of ophthalmology written by Yanov and found 56 mistakes in the textbook. And he sent one email to Professor Yanov. And he was grateful to our professor, Professor Dr. Asim. And he said, I accept. Few of them are really typographical errors. Few of them are actual mistakes. I will correct it in the next edition. So you people are from West Bengal. Once upon a time they used to say, what Bengal thinks today, India thinks tomorrow. So you people are from this glorious state, and I want you to read well, especially all the textbooks. Okay? Good, doctor. Thank you.
Thank you, sir. So far, we are having an amazing discussion. I would like to ask Dr. Pranav for the next presentation.
Foldable, flexible, fixable. T-haptic strategia in traumatic aphakia. I am Dr. Pranav Sairaman. Okay. Foldable, flexible, fixable. T-haptic strategia in traumatic aphakia. I am Dr. Pranav Sairaman from Second Sight South End Eye Center. No financial interest. 59-year-old male came with chief complaints of blurring of vision in right eye that was sudden in onset after blunt trauma by elbow 3 days ago. There was no other significant history. And on examination, there was 260 visual acuity in right eye, which was improving to 6.6 with plus 13 diopter spherical lens, and there was aphakia, and periphery showed dislocated lens. The fundus photo of right eye shows dislocated natural lens in inferior nasal quadrant. OCT was within normal limits. The patient was taken for vitreoretinal surgery. For the reasons I would tell in ahead, there was limited peritomy done and scleral flaps were constructed. The flaps are constructed 180 degrees apart, but not exactly horizontal, not to damage the ciliary vessels. After constructing the scleral vessels, 27 gauge 3 vitrectomy ports were created, anterior vitrectomy was done, and core vitrectomy was followed. Then vitrectomy was done thoroughly around the lens as well. And PVD induction was done using triamcinolone staining. After this, after successful PVD, a small amount of PFCL was injected to protect the macula, and peripheral vitrectomy was done under the lens and all in the all clock hours, and this PFCL protected the macula from the lens, rotating lens. And phacoemulsification was introduced and lens was uplifted and to protect the macula, and the lens was fragmented using this phacoemulsification, which is 20 gauge actually. And PFCL was removed. This is a CMT Flex IOL which has T-shaped haptics. This was implanted in this case. So this is a trocar and ports are created and CMT Flex IOL is being introduced. The forceps, it is very important to hold the junction of the T, not anywhere else, for proper positioning, and the haptic is taken out of the eyeball, and similarly on the other side. The incision made by trocar has to be radial so that the haptic is actually circumferential, that fits there. And fluid air exchange was done and eye was closed during using tissue glue, bioglue. So routine post-op medications, steroid antibiotic combination and medications to dilate the iris pupil in the first week was given. And results were as follows. In week 3, week 4, the visual acuity improved to 6.9, and just with 1 diopter or 0.75 cylindrical, it was to 6.6 BCVA, which was 260, and IOL was in place. So this is the post-op image. OCT was within normal limits. So to discuss, CMT Flex simplifies the process of SFIOL fixation according to studies, and even short-term complications were none noted, and even long-term complications were none noted, and it was effective method to correct aphakia. So to conclude, CMT Flex is a reliable secondary IOL option with innovative design, intraoperative ease, and small learning curve, and it has impressive stability in long term. I acknowledge. Thank you.
Wonderful. Congratulations. Don't you think he looks a little bit like Rashmika Mandana's boyfriend Devarakonda? Especially with that blink of his round eyeballs. Very good. Doctor, I am happy you took up this topic of CMT Flex.
Yes, sir.
And you spoke at the correct time,
Yes.
Because the person who has used the maximum number of CMT flex IOLs in India is right next to me, Dr. Sudeep Das.
Good
So I
morning,
will
sir.
ask him to give a comment on CMT flex.
I do it for different way. I don't use flaps. Originally I used to use Hoffman's pockets, and that will get published soon. But now I switched to using scleral pockets, like you do an SICS, small this ones, and so there's no flap. And I do it transconjunctival, so there's no peritomy also. Both Hoffman's as well as transscleral.
Okay, sir.
1 minute. I'll give you a surprise. Dr. Nivian, can I put you on speaker phone? Water. Now, to give you a pleasant surprise, I have asked the inventor of the IOL to talk to us, Dr. Nivian Madhivanan. Dr. Nivian, can you hear us?
Yes, sir, I can hear you, sir.
Good.
It's a surprise for me because I don't know what is happening on the other side.
Okay. There's a wonderful talk going on here. There's a competition among postgraduate students. And one student had come up with your CMT flex IOLs. And he gave a wonderful presentation. Yes. And you know who's sitting right next to me? The person who's using CMT flex IOLs, Dr. Sudeep Das.
Yes, sir. Okay, sir. I have learned a lot and modified the technique after seeing Sudeep sir's videos. He has made it even more simpler to use it actually with the Hoffman's pocket.
Yes.
And I think the advantage will be also for the anterior segment surgeons.
Correct. Good. Any other messages from you, Nivian?
Right now we are in the conference in ESRS in Copenhagen, sir. So that's why the different time.
Good. So thank you very much for taking time to get connected to us from Copenhagen. Thank you, Nivian.
Thank you, sir.
Thank you. Righto. So congratulations, doctor. Good presentation. It is a good tool, and we have expertise here. So please watch. Where are your videos, sir? You don't put it on YouTube. Okay. Please do. Please do. It will be of great use.
Definitely, sir.
Thank you. Any other questions from the audience? Audience? Teachers? Yes, sir.
Was there any posterior complication? Posterior compartment complication, you did vitrectomy and all these things?
Sir, to mention, there was intraoperative peripheral hole was found. There was a break and it was lasered with endo laser. And because this was found, C3F8 gas was given. Due to the time constraint, I did not mention that. Yes, there was an intraoperative. I don't think it was iatrogenic. I think it was.
And you talked about phragmatome also. The lens drop was there?
Yes, there was traumatic aphakia. Lens drop was there. And to protect the macula, I used the PFCL was used and phragmatome was used in much above the macula. And there was no complication regarding the phragmatome usage. Sir.
Okay.
Thank you, sir. Sir, please.
Go ahead, you, sir. Go ahead.
What other modalities could you have used in this type of a case? Like how could you have solved this case other than CMT flex?
Sir, scleral fixated IOL is of multiple types like sutured scleral fixation, glued IOL, and CMT flex is another option. And if not scleral fixation, even iris fixated IOL is also an option. AC IOL is also an option. But scleral fixated would be my first choice. Among that, according to the availability and according to the affordability, I would choose between whether sutured scleral fixated or glued or CMT flex.
So why do you think scleral fixation will trump over CMT flex?
Sir, actually, like other modalities of scleral fixated over CMT flex? No, sir. I think CMT flex is better than other modalities of.
Why?
Sir, there are less suture-related complications, and there is less.
We use Yamane now. We don't suture.
Yes, sir. Yeah, Yamane is. It can be comparable to CMT flex, and learning curve of CMT flex is smaller than Yamane for young ophthalmologist.
How?
Sir, Yamane, we have to scleral
pull the haptics out and you cautery them. That's
yes,
it.
sir. Yes, sir. Pulling a curved haptic is difficult than pulling a T-shaped haptic. Yes. And
what material is used in CMT flex?
Sir, it is hydrophilic acrylic, sir. Okay.
It is hydrophilic acrylic. It is made by Appasamy Associates.
Yes, sir.
Right. Thank you.
The Yamane is that erosion there and late infections. I have had, before Yamane came in, we used to do the Agarwal technique, and I've had a haptic optic dislocation about a year after the actual surgery. And then a year after the actual surgery, the haptic optic disinserted, not immediately. Yeah, because the haptics are meant to be compressed, not stretched. And Yamane worries me because a lot of people, you try to push it into the sclera, but most of the time you'll see it's outside, it's under the conjunctiva. And that's a real worry for me because the conjunctiva can erode and then you can get an infection there very late. So I don't, I mean, I've done a Yamane, I don't do at all anymore.
So your preferred choice is CMT?
Now CMT. Any need for PI? No, absolutely not.
It is in a different plane, sir. To be very frank, the effective lens position is similar to the effective lens position of an IOL in the bag.
It's the same across.
It's in the same area.
Yes.
Right. Thank you, doctor.
Thank you so much.
Welcome.
Thank you, sir.
Yeah.
I would like to ask the next presenter, Dr. Orkoprabhu Mongol, to come up.
Breakfast is ready. This is a piece of information I want to share with you. But shall we go after these three people finish their talk? Good.
So good morning all the eminent guests present here. Today I am going to present a case of left eye sympathetic ophthalmia. I am Dr. Orkoprabhu Mongol, a postgraduate trainee, one from JIMS. So we have a 14-year-old male who attended our OPD with dimness of vision left eye, which was gradually progressing in nature. The patient had an history of blunt trauma to the right eye 1 year back, and on presentation the right eye was thicycle. So at the time of presentation, the patient had base corrected visual acuity of right eye, which was PL denied, and left eye was hand movement close to face. On anterior segment examination using a slit lamp, the patient had normal lids and conjunctiva, but the anterior chamber represented mild cells and mild flare, and the iris was normal, but the pupil was pharmacologically dilated, as in a previous OPD he was being treated for uveitis, for suspected uveitis or any spectrum of such diseases. On that OPD finding, at that time the patient had visual acuity left eye, hand movement close to face, and symptoms of photophobia, lacrimation and redness. The AC cells was 4+ and AC flare was present, and there were presence of keratitic precipitates. At that time the patient was started with topical steroids and mydriatics. And the time of presentation, the patient had posterior segment findings of vitreous cells plus, and fundus showed disc edema, blurred margins, and presence of Dallen-Fix nodules. So we had some differential diagnosis in our mind, and we ordered a battery of investigations like CBC, ASR, chest X-ray, the TB Mantoux test, and fundus photograph, FFA, autofluorescence, and OCT. The patient came back with the following reports. The chest X-ray, CBC, ASR, Mantoux test came out to be within normal limits. The fundus finding showed a disc edema, blurring of disc margins, there was tortuosity of the vessels, and there was dull foveal reflex. We can see in the fundus finding of the left eye the following the findings I just mentioned. The FFA findings in the early phase, they showed a bit of disc edema and blurring of disc margins with hyperfluorescent spots and a bit of pooling, which was noted which could be due to subretinal accumulation of fluid, sub-RP accumulation of fluid. In the late phases, there were prominent pooling of the dye, and hyperfluorescent spots persisted, and there were some hyperfluorescent leaks which could have been the Dallen-Fix nodules which are present in sympathetic ophthalmia. The OCT showed accumulation of fluid in the sub-RP layer. This was at the time the patient came back with the reports. So keeping the findings in mind, the patient was diagnosed provisionally as a case of left eye sympathetic ophthalmitis, and the following treatment protocol was started. The IV methylprednisolone was started. It was 1 gram in 200 ml NS, slow infusion over 1 hour for 3 days. following IV methylprednisolone treatment, the patient had improved visual acuity, which was visual acuity left eye, finger counting 4 feet. The patient was subsequently started with oral steroids such as followed, like tablet prednisolone 60 mg for 7 days, then tapered slowly up to 10 mg over a period of 1.5 months. So on second follow-up after 2 weeks, the patient had visual acuity of left eye 6/60. And at the third follow-up after 1 month, the patient had 1 month from the second follow-up, the patient had visual acuity of 6/24 partial. The patient also came back 2 weeks later and had a visual acuity of 6/12, which was not recorded. And this is the fundus picture after completion of treatment, which showed markedly resolution of the foveal reflex dullness and marked resolution of the spots that were present in our earlier fundus photograph. So this is the OCT picture after treatment completion, which showed resolving of the foveal thinning and the subretinal fluid which was there, sub-RP fluid. So coming to a discussion, sympathetic ophthalmia is a rare bilateral granulomatous panuveitis that occurs after penetrating trauma or intraocular surgery to the eye, leading to inflammation in the fellow eye. The traumatic eye is called the exciting eye and the fellow eye is called the sympathizing eye. Differential diagnosis would include VKH, sarcoidosis, infectious posterior uveitis like TB, syphilis and multifocal choroiditis. Prognosis is variable, but early diagnosis and aggressive immunosuppression improves outcomes. Delayed recognition may result in severe vision loss. Thank you.
Thank you very much, doctor. Which is the anatomical location of the Dahlen-Fuchs nodules?
So, sir, the Dahlen-Fuchs nodules are basically located between the RP and the Brooks membrane.
Very good. What is the histopathological nature of the Dahlen-Fuchs nodules?
So, these are basically granulomatous inflammation.
Yes. What cells do you expect there? HPE picture with hematoxylin eosin staining.
Ellipsoid cells or macrophages, lymphocytes.
Yes. What are they? Histopathologically.
Epithelioid cells.
Very good. Along with?
Along with macrophages and lymphocytes.
Lymphocytes. Not monocytes. Lymphocytes along with epithelioid cells in hematoxylin eosin staining is the hallmark characterization of Dahlen-Fuchs nodules. And that is the clinching point of diagnosis in sympathetic ophthalmia. What is the name of the fundus picture in sympathetic ophthalmia? What is it called? For example, morning glory. Like that, there is one name, specific name.
Sunset glow fundus. Sunset glow fundus.
Sunset glow fundus is the key word. Very good. Any other questions from the other judges? Sir, Mike.
As a part of treatment, do we consider enucleation of the other eye?
Yes, sir. We could have considered enucleation of the other eye because it was physical and there was no good visual prognosis present on the other eye. So enucleation could have been a treatment option.
As a matter of fact, if it had been done earlier, there would have been no sympathetic ophthalmia in the other.
Yeah, that's true. But even subsequently, I think,
To save the only surviving eye, what Sarah has told, this is also indicated. Any presence of giant cell is there? Do you expect any giant cell in the HP?
Can happen in future, sir? Can it happen again?
Yes. Yes. And another thing, what is the relationship between worked Koyanagi-Harada syndrome and sympathetic ophthalmia as far as FFA picture is concerned?
So in the FFA picture, we can, in both the pictures, we can see hyperfluorescent leaks and choroidal inflammation. Also, we can see subretinal, sub-RP pooling of the dye can be seen in the FFA picture.
Yes.
And the Dahlen-Fuchs nodules would be present in both the VKH and the sympathetic ophthalmitis.
Exactly. This is the answer we wanted. Very good, doctor. Congratulations. Thank you.
Now I would like to ask Dr. Kunal. Please come up.
So, good morning everyone. Myself, Dr. Kunal Dongre. I'll be presenting a case of Vogt-Koyanagi-Harada disease, unmasking the great masquerader. So, a 41-year-old female came to the OPD with complaints of sudden loss of vision in both eyes, along with headache for 3 to 4 days. So there was no history of ocular trauma or fever or hearing loss. The patient was diabetic since 8 months, and the general and systemic examination were within normal limits. So the best corrected visual acuity in both eye was 1/60, and the IOP was normal. And anterior chamber there were cells present, 1+, and in vitreous also there were cells present, and the fundus shows multiloculated exudative retinal detachments in both the eyes. So this fundus shows the multiloculated retinal detachment in both the eyes along with the disc hyperemia. And the OCT of the right eye shows the subretinal fluid between the neurosensory retina and the RPE, along with the subretinal septae and the RPE undulated corrugations and increase in choroidal thickness along with the disc edema. So the left eye also shows the same image. So we ordered these investigations, and in that the TB platinum and TPHA was negative. So we referred the patient to physician, dermatologist and ENT specialist for further evaluation. So the differential diagnosis we can think of are probable VKH disease, sympathetic ophthalmia, acute posterior multifocal placoid pigment epitheliopathy, multiloculated central serous retinopathy, and posterior scleritis. So the fundus fluorescein angiography of the right eye shows the in the early phase it shows the pinpoint leakages, which in later phases coalesce and forms the large leakages, which shows the pulling of the dye in the detached retina. The left eye also shows the same image. So considering all the systemic ocular examinations and investigation, the most probable diagnosis we can think of is probable Vogt-Koyanagi-Harada disease. So we started the patient on methylprednisolone 1 gram IV for 3 days, then followed the patient with oral prednisolone with 65 mg tapered off subsequently for over 7 weeks. Also we gave the patient a tablet azathioprine 50 mg twice daily, and we followed up the patient every 3 weeks. So according to the study, the long-term prognosis of VKH is quite good. So the intravenous corticosteroids given at the onset of VKH are more effective than oral corticosteroids. Even if it is not given immediately after symptom onset, immunosuppressive therapy is able to reduce the incidence of sunset low fundus and to improve the final visual prognosis. So after 3 weeks, the visual acuity improved to 6.6 parts in right eye and 6.9 in left eye, and the IOP was normal. So after 3 weeks, as you can see, there was no subretinal fluid, and the foveal contour was regained along with the RP undulation were absent. So the left eye also shows the same image. So the modified diagnostic criteria of VKH syndrome includes the absence of a history of penetrating ocular trauma, absence of other ocular disease entities, bilateral uveitis, neurological or auditory manifestations, integumentary findings, not preceding the onset of CNS or ocular disease such as alopecia, poliosis, or vitiligo. If 1 or 2, 3 criteria are present, then it is a probable VKH. If 1, 2, 3 along with 4 or 5 criteria are present, then it is an incomplete VKH. And if all the 5 criteria are present, then it is a complete VKH. So VKH syndrome can present as bilateral serous retinal detachment mimicking other retinal or inflammatory disorders. High dose IV methylprednisolone leads to rapid dissolution of subretinal fluid and restoration of vision. So early recognition and timely aggressive treatment are critical to prevent the recurrences and long-term sequel. So I acknowledge and thank you.
Excellent talk, doctor. Very detailed. Now I will ask you a question. Vogt-Koyanagi-Harada syndrome. Embryologically, which group of cells are affected?
So the choroid layer is affected. Choroid is affected first. Melanocytes are affected.
Ectoderm, endoderm, mesoderm.
Yes.
These are the 3. Which origin cells are affected in VKH?
So the mesodermal.
Ectoderm.
Okay.
And in that, which ectoderm is prominently affected in VKH? Neural crest cells of the neuroectoderm. Okay. What are all the tissues associated with the neural ectoderm?
So is melanocytes, although the melanocytes in skin, ear.
Okay, good. Melanocytes. Are melanocytes ectodermal, endodermal or mesodermal?
Ectodermal.
Correct. Correct. They are ectodermal. But there is something called EMT. What is this EMT? He gave the correct answer, but it should be completed. What is EMT? In the neural crest cells in the 14th week, there is a transition from epithelial cells to melanoblasts. So this epithelium to melanoblast transformation is known as EMT, wherein the epithelial cells modify themselves into mesodermal cells. That is why it is called EMT, and that is how melanoblasts are created, and from there you get the melanocytes, and these melanocytes are found in the eye, inner ear, and skin and central nervous system. And central nervous system. Therefore, Vogt-Koyanagi-Harada syndrome will affect the eye, inner ear, skin and the nervous system because of embryology. Have you heard of a book called Langman's Embryology?
I have heard about it.
You would have read in your first year of MBBS. Kindly go there again and read about the embryology of the eye, which is chapter 13. Okay, right. Thank you very much, doctor. Thank you. Any other questions from the audience? Yes, sir.
Why do we study things as syndromes?
So it is multisystemic pathology, so we can...
Yeah, exactly. So that if you find one or two, you
Then
don't miss three or four.
Yes.
So that's what sir was talking about.
Okay, let us give this boy a nice round of applause and send him. Very good, doctor. Very good. Langman's Embryology.
Wonderful presentation by Dr. Kunal. Now I would like to ask Dr. Jyoti Chandak to come up for the next presentation. We have one more presentation left, and after that there will be a talk by the keynote speaker.
Good morning everyone. I am Dr. Jyoti Chandak. Today I am presenting a case, clinical red flags when the answer is written all over the patient. So, the Lawrence-Boone-Barrett-Biddle syndrome is the second most common syndromic RP after Usher syndrome. It is a rare autosomal recessive ciliopathy originating from consanguineous marriage, which is characterized with the primary features of retinal dystrophy, polydactyly, central obesity, genital abnormality and intellectual disability, and secondary features encompasses developmental delay, diabetes mellitus and congenital heart disease. In my case, a 9-year-old male kid walked into the OPD with a short stature, central obesity, post-axial polydactyly, with the chief complaint of gradual onset, progressive painless diminution of the vision in the both eye, typically after the sunset. The caregiver also noted about his poor school performance along with the developmental delay in the speech and the motor area, and his birth history suggestive of the consanguineous marriage, and he has no siblings. In the general examination, we found the height of the boy to be very short of 2.5 feet, the BMI to be very much high, 29.2, and post-axial polydactyly in all four extremities. In her general examination, the systemic examination, everything was within normal limit apart from the central nervous system, where in the mini-mental state pediatric examination, the score was 24. This is the image showing the polydactyly of the patient. In the ocular examination, the ocular alignment and the head posture was orthotopia and normal. Uncorrected visual acuity was 612 part, which was improving with pinhole to 6.9 in both eyes. With best correct visual acuity, it was 6.9 with 0.75 cylinder at 180 degree in right eye and 1.25 cylinder 180 degree in the left eye. The color vision was impaired. It was 2/17 in the right eye and 1 plate out of the 17 plate in the left eye. Rest all examination was within normal limit. In the fundus examination, which was performed with slit lamp biomicroscopy using 90 diopter lens and also indirect ophthalmoscopy with a 20 diopter lens, we significantly found a pale disc, vertical curve disc ratio of 0.2 mm, RP alteration at the posterior pole, pony spicules at the mid-periphery, and arteriolar attenuation. We also performed HBF 24-2 in this patient, where we find the superior field defect along with moderate to severe global depression, though the right eye was not that reliable. The OCT of the macula was within normal limit. In the systemic examination, we also found increased urea, creatinine, PPBS, and USG abdomen also suggested increased echogenicity of the both kidneys. Due to the financial constraint, we cannot perform the genetic study in this patient. Thus, treatment, it was mainly supportive treatment. We advised him a low-calorie diet and increased physical activity. We have taken opinion of pediatric endocrinologist and pediatric nephrologist for his raised and altered systemic investigations. Proper rehabilitation for the mental retardation and visual impairment to be done, and social practice of the consanguineous marriage should not be done. The differential are Alstrom syndrome, Cohen syndrome, Makossek-Kaufman syndrome. In discussion, in 1886, Lawrence Moon, and in 1920, Dr. Burdett described mental retardation, polydactyly, hypogonadism, obesity, and rod-cone dystrophy in separate cases. Later, Beadle described another 2 cases with a similar finding, along with gastrointestinal issues and skull abnormalities. Later, the pentad of the features were termed as Lawrence Moon Burdett Biddle syndrome. This is very rare, 1 in 1,60,000. Our patient had a feature of short stature, obesity, mental retardation, developmental delay, polydactyl, pigmented retinal degeneration, all along with the background of consanguineous marriage, which is indicating towards the diagnosis. Thus, early presentation to healthcare facility ascertain the multidisciplinary approach to manage the comorbidities along with the proper visual help to the needful. In conclusion, Lawrence Moon Burdett Biddle syndrome requires early recognition and multidisciplinary management to address its complex manifestation. Genetic counseling and supportive care do improve the quality of life of the patient along with throughout his lifespan. This is the patient ticket. These are my references. Thank you.
Thank you very much, doctor. Congratulations. Why is Lawrence Burdett Moon Biddle syndrome fatal?
Sir, because of it affects multiple system, cardiac system, renal system, and
what is the
respiratory
cause
system.
of death in Lawrence Moon Biddle syndrome?
So there is morbid obesity and cardiac disease, cardiomyopathy.
I'll come to the question directly. What are the structural and functional changes occurring in the kidney because of Lawrence Moon Biddle syndrome? You said creatinine is high.
Yes, sir.
You said urea is high.
Yes, sir.
Correct. What are the renal, structural and functional changes characteristic of Lawrence Moon Biddle syndrome?
As because it's also a spectrum of ciliopathy, sir, the function of the kidney is decreased, but exact pathology I'm not very confirmed.
The ciliary processes of the cells are affected.
Yes,
correct.
sir.
In which part of the glomerular apparatus do you have ciliary cells? Anyways, we have only one more speaker and very little time. Therefore, I shall curtain my questioning and let you go. Any other questions from the judges?
Wanted to know the answer.
Okay. There is this distal convoluted tubule.
DCT, yes, sir.
In the distal convoluted tubule, you have reabsorption. First of all, you have something called the glomerular filtration rate, which appears in the Bowman's cup. Then there is active secretion. After that, there is reabsorption of vital elements back into the system, which occurs in the distal convoluted tubule. After that, you have items getting in in the extract, and that is secreted as urine. During the reabsorption process, you need these ciliary processes to reabsorb the vital proteins, vitamins necessary for the functioning of the body. When that is not carried out by the ciliary cells, you tend to lose more vital vitamins, especially taurine, etc., because of which a plethora of nutritional deficiencies occur. And death is not because of cardiomyopathy, which also occurs, but death is primarily because of the renal disease associated with Lawrence-Moon-Beidel syndrome. On that note, thank you.
Thank you, sir.
Right.
Good morning. I am Dr. Rishabh Boiragi. I am a second year PGT in RIO Kolkata. Today we started the day with the quote, "What the mind does not know, the eyes cannot see." I'll end with the same.
What the computer does not know, the screen does not show. What the mind does not see, the eye does not know.
So I'll be presenting a case of choroidal melanoma with exudative RD. We have a 45-year-old female who presented with painless loss of vision in her right eye for the past 3 months, following a trivial trauma to the right eye while playing with her granddaughter. It was gradually progressive in nature. What was surprising was that she had a similar episode of diminution of vision 4 years back, but she did not have any documents available. Due to COVID and subsequent lockdown, she could not follow up, and she decided not to show up because her vision did not deteriorate any further. On examination, we can see that her best corrected vision in the right eye was as low as light perception with projection of rays inaccurate, and the fundus finding was suggestive of exudative RD, and the disc was not visible. In this fundus picture, we can see that there is exudative RD, total RD of the right eye, whereas the left eye fundus picture is normal. On careful observation, we can see that there is a mass lesion present in this region, hidden beneath the exudative RD, with a relatively well-defined margin and an orange pigment. We went ahead and did a USG B scan, which shows a characteristic collar stud appearance of dimensions 11 millimeter into 8 millimeter. To rule out any extra orbital involvement, we did an MRI, which shows a hypointense lesion in the right eye in T2 weighted images, which is adherent to the choroidal margin. The right optic nerve is edematous, as can be seen over here, and it is not involved by the mass lesion. So we wanted to rule out whether there was any metastasis, and we did a PET CT, which proved that there was no metastatic foci elsewhere in the body. It was around this time we provisionally diagnosed the patient with right eye choroidal melanoma with exudative RD. It was around this time that the patient got hold of some of the previous documents which were taken 4 years back, and we can see that here there is a subretinal fluid present on the OCT of the right eye. She also provided us fundus images, or images of the fundus fluorescent angiography, which shows bright spots just adjacent to the disc. However, she landed up later with a big lesion and exudative RD with not much vision salvage possible. So she was explained and she was counseled, and we went ahead and did an enucleation of the right eye under local anesthesia, and the specimen was labeled and sent for HP. The histopathological report confirms our diagnosis of choroidal tumor in the right eye, and it was proved to be malignant melanoma. The circumferential resection margin was free of the lesion. She was referred to oncology, and the oncology said that there was no intervention required. after 6 months of follow-up, an LFT was done, which was within normal limits, and the patient was planned for annual follow-up with the ultrasound of the whole abdomen and chest X-ray. At present, she is doing well. So, choroidal melanoma is the most common primary intraocular malignancy in adults, and it is usually a clinical diagnosis. We can diagnose based on the clinical symptoms itself, clinical signs itself. The main aim of treatment is to avoid the development of painful blind eye and to conserve as much as useful vision as possible. Thank you.
Excellent talk. Sir, questions? Kindly give the mic to Dr. Debashish.
Before enucleation, this is for everybody. Would you do something which is most important? Not surgical.
All the investigations work.
No.
Counseling, I said that, sir.
Counseling, something in that line? Well, since I understand that you don't know, always take a second opinion, every one of you. Evisceration, enucleation. How confirmed and pinned the diagnosis is, always take a second opinion.
As a matter of fact, in Tamil Nadu government, before evisceration or enucleation is carried out, the ophthalmologist who wishes to do the evisceration or enucleation must get the opinion of 2 other ophthalmologists from 2 other institutions and get their signature. So with 3 signatures of ophthalmologists, evisceration or enucleation is carried out in Tamil Nadu. I don't know how it is in other
states. Here we have to take the written consent from 2 other professors.
Done. Agreed. One more thing. Where does this metastasis commonly occur?
Most commonly it is to the liver, followed by lungs, bone, and other.
And everything else. Correct. What are the side effects? Nausea, vomiting and diarrhea. So like that. And other tissues. Very good. Okay. What is the genetic gene marker?
BAP1.
What?
BAP1. It is a tumor suppressor gene.
I agree. The reason why I remember that very beautifully is because yesterday we had biryani in Barakpur in BAPI, B-A-P-I. So it's the same gene which is associated with this disease also, BAP1. Very good, doctor. Any other questions from the audience? Sir, Professor Alam? Okay. On that note, shall we conclude? Yes. So thank you very much, doctor. It was a wonderful presentation. My hearty congratulations to all the PGs who did a great job, especially to that girl who came first with all the nervousness intact. It was a good presentation. And Vera Shaun, she had a good presentation. You did a good job. So did you. The intention of all these grueling questions is to prepare you for your postgraduate exam. We sincerely love you all, including that boy Devarakonda, who answered many of my questions. So the intention is only to prepare you for a hostile environment which you may face later on during the course of your post-graduation. On that note, a big thanks from all the judges. I really enjoyed doing it. Dr. Alam, Dr. Shweta, Dr. Abhishek, and of course, the cameo role played by our hero, Dr. Debashish, who had some wonderful googlies. So, congratulations and thank you. Should we declare the results now or later? Breakfast is not the result. Breakfast is the reward. Okay, Baba. Shall we give the... We'll give the results right now so that you can go eat happily. Yeah. Give us a minute. Senior members are there. They will do it. But I will tell you what I have done. I have given 80 out of 100. We'll of course compile and the final results will come. I request Dr. Shweta to do it because already I have earned the enmity of many people in the crowd. So you do go ahead and, sir, you should do the declaration of the results, but I will tell you what I have done. I have given 80 out of 100 for Dr. Pragya. Wonderful. Dr. Reneza Yasmin, 75 out of 100. Dr. Shaun, 89 out of 100. Dr. Debyani Das, Dr. Debyani Das, okay, 75 out of 100. Why? Why 75? Your presentation was good, but you did not handle the questions from the audience that well. Okay. Then Dr. Ayan Bhattacharya. Ayan, okay. Ayan, 83 out of 100. Divya Jain. Presentation was good, but there was no life on the stage. You have to be bold, you have to be well prepared, not just to answer the questions, but also to make your presentation forcefully. Okay? Good. Dr. Pranav, 75 out of 100. Sympathetic ophthalmia, Dr. Arka, yes, 70 out of 100. You are another candidate who has lots of gumption in you, but please present boldly and emphatically. Dr. Kunal Dongre, yes, 75 out of 100. Dr. Jyoti Chandok, 70 out of 100. Rishabh Bairagi, 75. Right. Now I'll hand this over to sir. He will do the totaling. You've done?
It will be declared on
You do it right now.
When you know your job, results are immediate. Treat on time, you get results immediately. Nice to see you.
Can we have a photograph with all the postgraduates together? Come. Yes, sir, that is correct. Senior postgraduate. Thank you. Thank you. Thank you. Let me take a photograph. So that, in case anything happens to me, I know who murdered me. This one. I was doing the total, sir. Okay. Photo, sir.
Hello, 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 hello. Hello. Hello, 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 hello. Ready. Hello. Hello.
Ladies and gentlemen, yes, the proof of the pudding lies in the eating. Now you all did a great job. The results are ready. I told you what I did. Now Dr. Parvez Alam will do the declaration of results, and he is responsible for all the outcomes.
For all the outcomes, and now I am ready to face you outside. So
So, apart from results, everybody has a very wonderful presentation, but because we had to give the numbers, so the first prize goes to Shawan, Dr. Shawan, with around 313 marks out of 400. 313. The second prize goes to Pragya. Yes.
Please come.
Yes.
Sir, give the gift. And the third place, sir?
Pragya got 308. 308 out of 400. And third, at number third, Dr. Ayan Bhattacharya. Ayan got 307 out of 400. So congratulations to everyone, those who got the prize and those who not. And
You missed your third place.
yeah, very closely you missed. You are at number 4.
Okay. Prasenji, where are the gifts? Or shall we give later? Okay, anyway, this is the
Gifts will be given later on.
You will get your certificates later on. Now let us all go have breakfast. Come. Professor, please come. You are not just professor of ophthalmology, professor of pathology also.
तो क्या हुआ?
Yes, sir.
We had breakfast first.
Oh, already?
Was late. चलो.
Please give come.
आने से ब्रेकफास्টে ঢুকিয়ে দিয়েছে তার জন্য ঠিক আছে আমাদের হয়ে গেছে বসো খুব ভালো বলেছে
না কুকুর বাদ কুকুর বন্ধ করে কুকুর না না যা আছে চলু এখানেই থাকা কোথাও যাস না অন করা
Sir? No, no, not kala jamun, sir. Hard, crisp on the outside, soft on the inside. Beautiful lash, different from gulab jamun. Then there is one rasa malai and rasa raj. And then there is mango rasa raj, chocolate rasa raj. All here. So, Dr. Wonderful time I had.
And even we are this one, like the Bengali one, they are never fried. They are mostly, like gulab jamun and all is actually come from inside. They are not there from here. They are all steamed.
Adarsha Hindu Hotel. I go there. The owner became so familiar. Hilsa Master, Dr. Veloti, everybody knew me. So they give me that Hilsa fish and mustard gravy. What? Okay. So that, and they have that grilled prawns. The big fellow. Oh. Do surgeries, go eat, come back.
You've developed a tongue for this
We'll ask her to give it. Yeah. We'll talk about eating. This is a much more interesting topic. Dr. Shweta, please come. You can talk to us now.
Hilsa is quite an acquired taste. So you've developed a taste for Hilsa.
You take off that.
The taste is
bones, you just take it out.
unless you have it 3-4 times.
No. From day one, the day I went for lunch to Adarsha, he gave that fish. And that he said, you want basmati or regular? I said, whatever Bengalis eat, I want that rice. I wrapped it up in that gravy and put that hilsa.
Good fish will have
Excellent. But with that mustard gravy, it's a thick, creamy aroma. I hope he has served hilsa fish today.
Mustard is something which was never grown here. Not
It
in
came from
India
Punjab.
also. It came from the Britishers.
Still, you have acquired it and made it Bengali. Many British members got converted into Bengalis. And many Bengalis got converted and became brown British Sahibs. Brown on the outside, white on the inside. That's why they're called coconuts.
A very good afternoon, everyone. I am honored to be speaking here, and I would like to thank Dr. Pradeep Mohanta sir for giving me the opportunity. So I'm talking about this because I did not finish my PG very long ago. It's only been 2 years since I finished my PG, so I think that's why sir thought I should give a talk about the current scenario of PG training in India. When you're a postgraduate student, So when you're a postgraduate student, what are you expected to do? It's an MS in ophthalmology. So you're expected to know medical management as well as surgical management of cataract, at least cataract. In the earlier days, they used to give squint and many other surgeries as well. But now, by and large, because of super specialty coming in, that's not given anymore. In terms of medical management, everything is well covered. You have regular case presentations and you have regular journal clubs and all happening in colleges. So that ensures that you have a good clinical acumen by the end of it and you're confident in medical management. You are able to diagnose well and treat well. So that is one thing which is definitely covered well in PG. But I do think that surgical training sometimes may fall short. I'll put it in a very diplomatic way, but I think it falls short in many institutes, or at least as far as my experience was concerned. So, by and large, SICS is given to most PGs, and I think that's a good thing because SICS is the stepping stone to Phaco. You need to know SICS before you do Phaco, and in many situations, you're not able to do a Phaco at all. Like if there's a rhexis run out in a mature cataract, then you have to convert to an SICS. So if you don't know an SICS, then of course you're lost. However, when it comes to Phaco, I think things fall short. In most institutes, I don't know about everywhere, but as far as I've heard, Phaco is given, but around maybe 10 or 20 in PG. And there are limited institutes which give 50 to 100 cases or more. And 10 to 20 is not actually enough because Phaco, you need to use both your hands, you need to use both your feet. The foot pedal adds an additional layer of difficulty. If you're not able to control the foot pedal, you can't chop, you can't do many things. You also end up holding the posterior capsule during the last step, during the last piece. So these things cause complications like PC rent. So I don't know why why the training is not enough, but it's probably because of maybe lack of a retina backup, lack of enough patients in various private institutes, or maybe there is higher cost of foldable lenses. Patients are not able to afford the 2-3 grand which comes for even basic Apasami lenses. That could be one of the issue. Then the other reason also why this is happening is because now MBBS seats have increased so much that PG seats are also increasing a lot. And because of this, many institutes which don't have the equipment or the faculty, even they are admitting PG students. So I think that is why this is not happening. There are different ways this can be dealt with. So I think before PG start with SICS or Phaco training, they can go for simulation programs. I personally have done 1 week of Help Me See. I had done it in 2022, and that time it was free, but now I think it costs 20,000 rupees or something for 5-6 days of training. When I had gone, it really helped me tremendously, and after that, my SICS improved dramatically. Now they have also started Phaco. I've not gone for a Phaco simulation program because by then I'd already done Phaco surgeries. The other thing that can be done is using GO ties. So GO ties are not exactly the same as human eyes, but it helps you, it'll help you with your movements and other things that can be refined. And also I think that like MS is a surgical, MS is surgery, right? Like any surgical branch, you only have case presentations and vivas in the finals. There's no surgical exam. So I think that maybe if a surgical exam is introduced after PG, at the end of PG, it may put more pressure on the management to teach students. If there is, of course, there are other issues like lack of patients in many institutes. They don't conduct camps, all of that. But if NMC has regulations on the number of surgeries given to PGs, or if in America and UK, I think there's some minimum number. I think you have to be given 200 Phacos, or you have to be given 100. That's what is the rule in UK. I think UK has 100 and America has 200. So of course, if there are minimum number, if there's some guidelines, then maybe things can improve. The other thing is that maybe weaker students can be focused on if there's a surgical exam in the end. So then that will ensure equitable distribution of cases also. And also, if it may not be practical yet, but if there's a retina person coming in to handle the complications. So if there are 2 days of PG training, so that day only if PG training happens in Phaco. So those 2 days, maybe a retina person can come to handle the complications. I don't know how practical this is in the real world scenario because I have not gone into private practice yet. It's only going to happen now, but these are the ways I think it can be improved.
These are your perspectives.
These are my perspectives as a former PG. Yeah.
Done. Before that, Dr. Pradeep Mohanta, how many minutes do we have for discussion? Because this is a Pandora's box. 5 minutes. In that case, we will be very, very brief in all the comments.
Okay, I'll just make
You
a comment.
start,
I'll just make
yeah.
a comment. Shweta, thanks for that insight into PG training and what you want. Now we have stalwart phaco surgeons over here. None of them have had a phaco training.
Yes, sir.
Okay, so that is something I think we all need to keep in the back of our mind. Most of us are self-trained. Okay, so when I finished my PG, we barely came out of a ECC IOL. Okay, so all of us, so if we can self-learn, and actually I jumped into private practice straight away. That's audacious. Okay, so what Sudeep was telling us, that yes, the MS gives you makes you a comprehensive ophthalmologist. You do need that. The cataract part is heart and soul of our bread and butter. So that skill you should learn over there, but hands-on, even if it was not there then, if it is there, very good. But even if it's not there, you can still go ahead and do it on your own, and you have training centers. So don't.
Sir.
Done. Dr. Parvez Alam, short comment.
There is no doubt about that. We had opportunities in those days. All are self-made. We tried our best. We learned from here, there, and attending
Everywhere.
conferences like that, CMEs.
Okay.
So, if it is not today, nothing to be very worried.
Yeah, there are multiple opportunities to
I
learn.
agree.
But now lot of options are there. Even videos were not available in our days. So that is, and Pradeep Mohanta
Good
sir.
point, good point.
So that is a great thing. Mane, we can learn now. Even I did not, I was not doing autograph pterygium. So after seeing on videos, I am doing now. And doing good number of like that. So if you get a chance, if you will try, if you will strive, definitely you are going to make your place.
Thank you, Professor. Now, Pankaj.
Just another question.
Yes.
How many PGTs is here? Just simple question. How many of you have done the dangerous sutures, really unburied suture? How many of you?
I mean, I'm not
Only PGTs I am asking. Out of?
Yeah. No, I'm just suggesting Dr. Sweta, because do you think incorporating ECC IOL in the training program, because what I have learned practically, we started with ICC, then ECC, then Phaco, and after that we started SICS. And to me, SICS is little difficult compared to this ECC IOL. So it's my suggestion that all the PGs, they should start with ECC, and as Dr. Sarkar said, they will get the opportunity to put sutures.
Do the suturing.
And because in SICS is challenging because the capsule
But they can always suture oranges and get training.
But in SICS, you have to make a larger rexis, which is technically little difficult for the beginners. That's
Yes.
what I felt.
Agreed.
And another point you have highlighted is regarding the surgical exam in RP center, we had to perform in front of the external during our practical exam. And that actually is, no, that after that, no, you will become so confident that you can start your practice.
Private,
so
yeah.
that you should include in the thing.
Dr. Pankaj.
See, what Sweta said about the proper training, a lot of us, we have learned ourselves, but the proper training program, it brings down the learning curve.
Yes.
So there is no doubt about, there is a place for the
What
proper.
you mean is monitored training program.
Yeah. See, basically proper. I was associated with the Phaco training program for the 3 years. The Sir Ratan Tata Fellowship in Shankar Netrajayoti, it was started when I was there. So I learned Phaco by somebody else supervising. My learning curve was different. That's a different issue because before that I did 1000 ECC IOL, 1000 plus SICS, and then I have gone to the Phaco training program. So that was a different scenario, but not everybody gets that. So a proper training program like ECC IOL, You have to learn the suturing properly, number one. Because lot of traumas and all that thing, I've seen people, they struggle in proper way of suturing. So ECC IOL is also very important. SICS, I said, it's you have a different opinion, but it's a beautiful surgery. Everybody should learn. Your transition becomes very fast when you learn the SICS and then go to the Phaco. So you are master for all that thing. You can manage even later on. If some cases you are not able to manage the Phaco, if you know the SICS, if any problem is in between, you can definitely convert that. So definitely it has a role of the proper training program.
Professor Mrinal.
Ma'am, are you have passed MS?
Yes, sir. And I did fellowship also in Squint.
Where from did you do your MS?
Sir, Maharashtra.
Maharashtra. Now, whatever we think or any state thinks, it is immaterial. The total education system is under control of NMC.
Yes, sir.
And it is
Wonderful.
highly structured. Every moment, every second of your 3 years is counted and structured. What you do, what you don't do, everything has to be reported and documented. It is called CBME curriculum.
Yes.
In our days, house staffship or house surgeonship did us and taught us the practicals. We used to roam about here and there, everywhere with the boss under whom we were trained, and practical teaching and learning came from that. Theory, it was my responsibility or our responsibility to do it only for the exam. There was no semester exam, nothing else. Everything is structured now. Even residency program in the district, it is compulsory for 3 months.
Yes.
So every moment of you is structured. You have to learn that. We don't give only importance in the practical doing cataract or very, very sophisticated surgery.
Agreed.
It is for the need of the nation, the minimum things which you should know before passing.
Thank you, sir.
If the structure is good, the superstructure you can easily do it. I and Dr. Mahanto passed from the same institute. We got exposure to practicals enormous. But what Mahanto could do, anybody could not do, because his own perseverance and
Opportunities.
exposure. So the CBME curriculum which is in vogue now, we have to follow blindly. There is no other way. You cannot stand for the exam unless you present your case just like this, and in podium at least a poster. That is the minimum
Paper,
to get
poster
the
and
admit
publication
card,
is compulsory.
admit card. You have to present your paper in public. And another thing has come in this era, that is research. Whatever you do, maybe meta-analysis, you have to do it. In our time, only doing a dissertation was sufficient.
Yes.
Now, they have got given enormous responsibility on the teacher and the student to do research and publications. That was not in our time.
Sir, I agree. But there's one thing I would like to tell you. In 1950, when Dr. Ambedkar presented the constitution to the country, he said, in this constitution, there are stipulations, statutes and regulations to determine a country rooted in democracy. However, if the rulers are irresponsible, this constitution will be useless. This is what Dr. Ambedkar said. Now, NMC will have come out with rules and regulations, but if the professor and HOD is not up to it, that entire NMC constitution is useless. However, I don't wish to provoke a political debate on this. Dr. Pradeep Mohanta, on to you.
Yes, we think it may not happen immediately. Dr. Shweta has said something about surgical exam. I think this should be a part of the exam, at least how the surgery is being done by the candidate. That should be a part of the exam. Anyway, but what should be and what not should be, that is in your thinking level. It may happen, it may not happen in future. But the PG students here, they have to learn somehow. Surgery you have to learn somehow. Suppose you are not getting chances to do surgery now. I also didn't get any chances during my post-graduation in ophthalmology. So what I used to do is I just cut something, say gloves or something, take a 10 nylons from sister and just suture under microscope. So this gives the orientation to microscope. It increases your depth perception. So even if you don't get a goat eye, just cut something very thin, even very thin gloves itself, and suture with 10 nylon. This will increase your hand-eye brain coordination.
Sir, we'll conclude. We'll just get two opinions. Dr. Sudeep and Dr. Debashish. Brief comment on PG training. What would you like to have?
Well, my daughter is about to join ophthalmology now, so we've done a lot of brainstorming about this. And we still, of course, counseling hasn't started. And so she can join anywhere in India based on her rank. But what I realized and what I told her is that you can go to institution and become a master in cataract surgery, but that's not the thing. The only time that you learn the entire ophthalmology, get a broad picture, is during MS. After that, you narrow it down to something and you're not going to learn anything else. If I know about ophthalmology, the entire ophthalmology something, it's because of those days, 30 years ago. And that is the most important thing, not surgery, not what present day people call it as cutting chances. That is horrible. Yeah.
I cannot agree more to what Dr. Sudeep Das has said.
Okay, sir.
This
Thank
is
you for agreeing. What is your opinion?
Yeah, I mean, surgery you can learn at any part of your career. That's the takeaway. So I don't think a proper academic and clinical exposure. It is unfortunate that many private colleges, as she pointed out, do not have sufficient patients in the OPD. Like this is something which you will miss when you go into practice. You don't see 500 patients, this is not available. Whereas in our days, I think every medical college had 1,000 OPD, 500 OPD per day.
It's important to diagnose viral keratitis.
Absolutely.
Here, Suven, I would just like to add a personal note. When Dr. Suven and I were in Tamil Nadu, he was in Pondicherry, I was in Annamalai University. There were 1,150 MBBS seats in Tamil Nadu and Pondicherry, put together, 1,150. Today there are 13,500 MBBS seats. But the population has not gone up tenfolds. Number of MBBS seats has gone tenfolds. Population has only doubled. So that is another criteria which we have to live through.
But when you sit in the OPD, if you can't diagnose day-to-day problems, which you learn in your MS, because nobody is going to teach you after that. That is where we learn. So both are important. What is important? Both are important.
Agreed. Dr. Pradeep Mahanta, we are through. Yes, so congrats, Doctor.
So
nice talk.
Thank you very much.
Thank you.
And now we are going to the deferred live surgery session. I would request Dr. Pankaj Rupalia and Dr. Suven Bhattacharjee to conduct this session.
Dr. Pankaj,
Yes, sir.
you were in Shankar Netralaya in 99.
Yes, I was there in 1996.
You were born.
Yeah, I was there.
Because Dr. Partho and I, we were there at that time, when Tapan was also, and Madhu. I was with Dr. Vijaya and Lingam Gopal. Sir, well, Dr. Sudeep Das is the next, not the next, the first deferred surgeon who shall be talking to us. Ladies and gentlemen, I take great privilege in introducing Dr. Sudeep Das to you. He has been a prolific surgeon who has risen through the ranks. He can do an ICCE, ECCE, SICS, Phaco, with anesthesia, without anesthesia, microscope with LED, without LED, and if there is no microscope, he can do under a loop also. He is that kind of a surgeon.
I've never been comfortable with the loop. Never done.
Anyways, in case of any emergency, he will be resourceful enough to complete the surgery. Sir,
so
on to you.
This is not the one I would like to show. And actually, Pradeep asked me whether I want to show this or I wanted to show one of my recorded videos. I said, no, I'll be bold enough to show this. This is not definitely something that... So at the outset, I would say that my normal surgery is with a very long chopper. I use something like this. I'll probably be using a 1.75 millimeter needle-like chopper, or the modified Mohan Rajan chopper. And so I work completely within the bag. Yeah, so I work completely within the bag, and it wasn't there, so I had to use a horizontal chopper. And yeah, but I can't control it because it's long, so I'll have to sort of fast forward in places. So in between there was no signal for whatever reason, and then it came back. So this is my normal, it's not a small rhexis. My rhexis is normally about 5 millimeters or slightly smaller because I do a direct chop. And the thing is, I didn't realize, I'd actually seen naked eye, I should have realized I'm presbyo. And I thought this was a sharp chopper till they gave it to me. And then I realized it's a horizontal chopper. It doesn't have a point. So this is a normal thing. It's a very hard cataract, NO5 or something. You go by the locks. So normally what I do is I make a trench. This machine I'm fine with because this is the one I use now. I've used Centurion for 16 years and then went to an Earthly for the last 1 year, and I've been very happy with it. So I do a trench, a crater in these cataracts. Earlier I would do a direct, and this is when I realized that, oh my God, this is not it doesn't have a tip. Now what do I do with it? So I didn't want to go to the extreme. The first time ever I'm using a chopper like this, so try to separate this. But then your game plan is sort of completely gone by this time. So I still managed to get a complete chop here, not the first one.
Dr. Mahanta, what chopper have you given to him?
No, he didn't give, I chose, he had various, but there was no sharp chopper. So this is again, it's a complete chop. And just watch this area. So this chop is also all right. And where I'm manipulating, though the top is supposed to be blunt, I'm not really lifting it up, the rhexis gives way here. I didn't nick it at all. It's the back of the thing. The back of it. I'm not going over it at all. And you can see it's gone here. So now what do? Now I'm sweating. And so I know that I've separated two pieces completely. I thought, okay, I'll remove those to create some space in the bag. So I go to that. This is completely separated, pull it out. Because I don't want to stretch the bag when I'm chopping. And now all my maneuvers are outside the bag. Because if I stretch within the bag, the capsule will give way, the PC will give way. So this is also almost out. I remove that. And yeah, and then actually I managed to remove the entire nucleus without any problem. But you can imagine how you're feeling when it's a different machine, it's a different microscope, different instruments. There, in my own setup, sisters will know exactly what to give me without me asking. And everything is still all right. So then I come out, and it took some time to get the viscoelastic. I should have actually put the and then this is where the PC goes. Because the PC came up, the visco they didn't hand me the visco immediately. Not their fault, they're not used to what I do. So I was asking for visco, maybe you call it something else here. And this is where it happened. The vitreous still hadn't come. And then I sort of remove some of the cortex, inject visco, and then this is still there, there's still no vitreous. So I thought, okay, I'll put the IOL. I would have converted into a rhexis if I had found an edge. There was no edge. So I put this IOL in the bag and then removed the cortex. The very fact that I'm able to remove the cortex means there's still no vitreous. And then I realized that this margin here is very, very small. This side there is a good PC margin, this side is very small. So that's when I sort of decided to, and that's when the manipulation, the vitreous has come. So I'll go to the next video. That's when I thought of that I can't leave this IOL behind, I'll pull it out. So I did a bit of vitrectomy there, and actually the lens sort of centered, but I wasn't happy leaving it there. So there's no vitreous, you see the lens is pretty much centered, but this rhexis margin is very, very small. So then sort of what I do is, I sort of decide to pull it out. So go behind it, inject viscoelastic. Then bring the one haptic into the wound. Then I thought I'll use the IOL cutter, but then that was really fat. This was really fat. I was scared to put it into the eye. So I just took vanas which are fantastically sharp, which I actually like, really sharp vanas. Only Pradeep, I don't know whether you will be able to use it for anything else after this, after cutting the IOL. So you don't need to bisect it into half. All you need to do is cut beyond the midline. And once that is done, sorry. Once I prefer to use a toothed forceps for this, but here I was using McPherson, so that one haptic came out. Then you rotate it and pull it out. Rotate it and pull it out. And now actually I'm free to do a proper vitrectomy. Other thing I realize now is that I use the Cataract 3 with SPEEP. That actually they gave me the vitrector the first time when I did before this, and it wasn't working, and then they had to go and switch on the compressor. I didn't realize that Pharos doesn't work without an external compressed air. And then the pupil was small. So then I was whatever little cortex, because I've done a vitrectomy, actually I can remove all the cortex now. There's no fear that I'll aspirate vitreous anymore. And then I asked for a multi-piece lens, and this is again a sensor multi-piece. My go-to lens is the MA60, which is a closed cartridge. And so I had to think like, oh my God, now how was I loading this lens 20 years ago? So anyway, so that was okay, the loading was all right, only it comes out the wrong way.
No, there is something about the loading I think should tell everybody.
Yeah.
That the tail of the haptic that should stay out.
Yeah, that is correct. That is what I've done. I don't know if you can see where is the
injector.
So this is the tail of the haptic is outside. The last haptic is outside. Only this I thought I should keep it straight.
Once you put it inside the injector,
yeah.
The cartridge will remain out. Then you take the tail, and the tail should be turning
this haptic wasn't the problem. The leading haptic was the problem. Leading haptic came out the other way. Yeah.
See, you took the tail inside.
No, tail is not inside. Tail is still outside. That didn't give any problem anyway. So here basically I'm sort of rotating my wrist.
And that's because you're used to MA60 AC, which sweeps actually.
Yeah.
MA60 AC
yeah.
will sweep from the right to left.
Yeah.
Okay, this goes in absolutely straight.
So anyway, so implanted. I knew I'll implant it in the
I don't use MA60 AC. I use only sensor.
So my whole idea was to put it in the. See, the thing is, if my tear was somewhere else, I would have actually implanted directly in the sulcus. Here I can't do that because the tear is just opposite where I'm injecting. So injected into the anterior chamber and then sort of brought it into the sulcus. So this I'm making sure that it's between the iris and this I was wondering whether I should just put in hooks or something and make the pupil a little larger. Yes, people are larger, it becomes so much easier.
Excellent, sir. Now, if you
I think he deserves a round of applause.
No doubt about it.
Not saying, and this is the first time ever I've had a PCR during a live surgery. Not live surgery, deferred live, whatever, done deferred live also.
So, what would you have done differently if you are given an opportunity to go back by 2 hours?
I would have carried my chopper and come.
I thought about asking. You would have brought your chopper.
That last time I brought my entire instrument set. The problem is when you bring an instrument set, you have to check in your luggage. I really didn't want to check in luggage. And I wanted to just come through.
Okay.
There is one very important point what he said. Before taking out the phaco probe, you should have injected the viscoelastic. The last week, I was doing the live surgery and I had the same problem. See, I was not carrying it. I never carried my instrument and I used dialer and somebody gave me the chopper, which I didn't realize actually. Okay, in my flow of surgery, I did everything was over. Suddenly, when I was removing epinucleus by the phaco probe, that time I just touched the rhexis and had a rhexis extension. But only thing I realized, before taking out the phaco probe, put the viscoelastic. If you had taken out before taking out, put the viscoelastic, the visco would not have come probably, and we would have avoided the vitreous. If we can avoid the vitreous, then things would have been very easy. So basically, that's one very big take-home message is there.
The thing is, the PCR happened because the anti-hyaloid
Face was, that's why. That's what happens. Yes, if you would have avoided the PCR, then the things becomes better. Take out the cortex.
Because I've done the difficult part. I've removed the entire.
Yes, that was the most difficult part.
Yeah, and I got a PCR after that because I didn't inject.
And the other take-home message is, if you have a PCR, if you have done the vitrectomy, then it's always better to put the 3-piece IOL in the sulcus. These are the two very important message for all the PGTs.
So why did I remove this? I
Yeah.
mean, some people will be tempted to put this in the sulcus. But then these haptics are very thick and you're staying very anterior. It rubs against the iris all the time. And there are multiple cases where surgery done elsewhere. I have removed these because of UGH syndrome.
See, patient can be fine for few months, and then suddenly you will see patient will come with recurrent inflammation and all that thing, uveitis, glaucoma and all that thing. So once in the primary surgery itself you have taken care, I think that's something which is the wonderful thing is there. It's a great surgery, thanks a lot. And it really needs guts to show this kind of surgery in a live surgery session.
Not just guts, honesty and integrity.
Yeah, honesty, integrity. That's what the thing is. Yeah. Now, next speaker is Dr. Rudro. He doesn't need any introduction. He is the Rudro itself.
Thank you, chairperson, moderators, and my dear friends. I'm going to present a case of grade 3 to 4 nuclear sclerosis. Is a middle-aged lady, and the surgery is performed under topical anesthesia.
So, forgot to ask, topical or block?
No, block.
Block.
Thank God. Normally always
So I'm lucky the pupil is quite dilated and the patient was quite cooperative. So I started doing my side ports. So let me fast forward. I want to show you one thing. See the way I do my side ports. I don't use
yes, just a question. The side port, should it be facing us or away from us?
It should be facing us.
Here it was facing the other way around.
Because of the base phenomenon, if you're doing under topical, if the patient moves the IR, we get a big card.
It should be facing us.
So it should face out.
There is a better way to control that. Use a MVR blade.
I use something like an MVR blade, so I don't have a sharp edge like this.
Pankaj,
another blade.
In
1.1.
Our surgeons, when they taught us, they said the side port sharp edge should face the surgeon.
So, sir, I want to add something. As you are asking the side port, why I do this thing, as because when I am doing the side port, Yes, as because the patient sometimes, according to the Bell's phenomena, the patient pops his or her eyes upwards, and that's why the side port increases. And with the help, with the sharpened down, I can pull the eye towards me. That's why I do this. I do this intentionally.
Okay. Yeah, that's fine. But if you use either the bent MVR blade or 1.2 keratome, then you will never have any extension. You will have a wonderful side port. So all the juniors, they can try that. Use the 1.2 keratome to make the side port. You'll have a beautiful side port without any extension. It will be always same size.
Sir,
another point is that, sir, I do this thing as because you can see me in my next step. I put my keratome with my side port inside. I don't use see the next step.
You're using it to stabilize the eye.
See, yes, I used to stabilize it. That's why I do this.
But Rudra,
yes.
You can do with the same keratome as well the side port.
Yes, that I can do. But this is my preference. I'm doing this for years.
Good. One more thing, Dr. Pankaj.
Yeah,
you said our postgraduates should choose MVR blade. They are not able to choose cataract surgery for themselves. You want them
How
to
can
use
they get a
MVR blade.
No. If you get the keratome, you can get 1.2 keratome also. See, it costs same. If you use the keratome, anyway you are using 2.7, 2.8, 2.75 keratome, you can get 1.2 keratome the same cost.
Okay.
So there is no problem in that.
Right, come.
Yeah.
Go ahead, sir.
So I am putting some Phacoemulsification plus inside the anterior chamber that maintains the dilation of the pupil as well as it gives some anesthesia. And I have done an extra step which I don't do elsewhere. I have put some, as I have seen in the table, blue is lying, and that's why I have put some blue inside. Obviously it gives some extra contrast, but with advent of the newer microscopes in this type of cases, usually we don't use blue. So I am using a HPMC and putting it inside the anterior chamber to make it inflated. And I usually do my capsulorhexis. I usually do my capsulorhexis with a bent 26 gauge needle, and I bend the needle myself. Yeah, I try to do a 5 to 5.5 millimeter central circular rhexis. Sorry, as the centration is not good. And in this type of cases, I usually do 2 to 3 quadrant hydrodissection. With the 2 quadrants of hydrodissection, I get a good free nucleus inside the capsule. And to be sure, I rotate the nucleus with the help of the cannula itself. Though I routinely do rotation of the nucleus, especially after seeing cases demonstrated by Dr. Neto Rosatelli from Brazil, he usually rotates the nucleus 10 times in one direction and 10 times in opposite direction. That helps in freeing the cortical matter from the equator itself.
Dr. Rudra, not only that, in addition to that, he puts the sustainer inside and does it.
Yes. That is very risky. I don't use it. What
No,
Dr. Neto uses.
actually what it does, it polishes the LE cells in the equator.
Yes. And he doesn't use a IA cannula to wash the cortex. His phaco probe does all. Acha. My standard procedure of phaco is crater and chop in this type of cases. I do a crater in the middle of the nucleus, and through that crater I'll do a chop with a sharp chopper. I'm fast forwarding a bit. This is a Oatley Faros composite machine. I'm doing the crater.
This is why Pankaj was talking about the side ports.
Yes. For that, MVR is the best, I admit it.
1.2, use 1.2, you'll be very happy.
Yes. So I do my first chop with the help of this chopper, and I got a nice chop. And then I'll rotate the nucleus and do it 90 degree of the first chop. Did a second crack. This is my third crack, and I'll go with the 4 parts of the nucleus. And I did another one so that the central hard part is free. I always try to make the central part free, which is known as the patellar fracture. I don't know PGTs whether you are familiar with this term. I'm so sorry, it's not. Actually, no one told me in the OT
I have
that.
my reservations about.
It is better to use the retroillumination, which has a small field. And then
So I have a reservation about deferred life surgery and life surgery.
Yeah, now
that
I
is one
understand.
part. Secondly, because it doesn't
Live, not live, only
both.
deferred.
So whenever life was there and deferred life, both are not very serving a very useful.
Actually,
purpose.
this concept of deferred life is emerging.
So
It's
the
not a
question is,
foolproof.
if you want to see deferred life surgery in real time, it's going to be really long and it's going to take away
Yes,
time.
yes.
Okay. Secondly, now actually, if you want to keep the field center, you have to have a very good circulating nurse in the theater, not your assistant. Later on, you'll become adept at looking at the monitor.
Yeah.
And then you learn to keep it in the center, but you have to have a circulating nurse telling you, sir, center.
Rudra, stop 1 second, just go back. I'll just check the opinion of the parents whether they would like to ask the PGT to.
No. I will not recommend. The PGTs to do this.
Do the epicortex with the chopper.
No, that should not.
No, other thing to know is, all of us do this, but you're actually using the back of the chopper.
Sideways, side of the chopper.
You're using it up and then lifting it, so rotating it from behind. You're not holding
But it's always, see, chopper has already served the purpose. So take out the chopper.
Keep a second
and
instrument.
So chopper has already served the purpose. You don't
So
need
it's a
chopper for
it's a
initial
laziness
stage.
to take it out and
No,
put
for
another.
initial stage for the PGTs, not for you.
This was the thing I was saying.
It doesn't make sense.
They should take it out and put some viscoelastic and put a IA cannula and do the same.
चलो हाँ stop नहीं करने का.
So I'm almost done. So for the remnants, for the residual
I would
cortex-
like to put viscoelastic at this stage also.
No, I'll be doing
just
this.
Just a minute. Because I like to take out my side port instrument, whatever is there, inject viscoelastic and put the then take out the phaco. There's a reason for that.
Yes.
I've had a
Aqueous
fluid misdirection and a hard eye because I did not do this. So after that, I always put a little bit of visco at the incision site. I bring it from the side port and at the incision site and then take out my.
Suben, there's another matter. Cystoid macular edema is directly proportional to the number of fluctuations and jumping jacks which take place in the diaphragm of the ciliary body.
And especially in a nanophthalmos when you are operating.
Dangerous.
Yeah, when you are operating, this is must. Here you can get away without putting the viscoelastic. If you are operating on a nanophthalmos, any eye which has a less axial length, it has to be first put the viscoelastic, then only taken out. Because in a fraction of second, you can get the effusion, and then you are in a soup.
The hard eye,
yeah, so it's very important.
So, and the visco does not have to be all into the antechamber. Just under your incision, to plug it. Now, as you take off the phaco probe, it just plugs the incision. And then you go in with your IOA.
So I'll be implanted a hydrophobic EDOF lens, Hoya Impress. Yeah, this is an hydrophobic EDOF lens, a fantastic lens, and the best part of this lens is the its implantation is very hassle-free. It can go through 2.2 incision also.
No doubt, Hoya injector system
any lens of Hoya is the best.
No doubt about that.
Yeah. in this thing, I'm especially referring to the PGTs, if the lens flips, you have to learn how to make it in the normal way. This you have to learn. Sometimes it flips. And this almost
Dr.
comes
Pradeep
to the end.
Mahanta, did you operate today?
No.
No.
Why not?
He's taking
He
rest.
operates every day.
He's taking rest for one.
Yeah. What? Yeah, today. This is the marriage.
No, no, it didn't get
Oh, I
So finally, I'm removing the viscoelastic. That's also very important. You have to wash the viscoelastic in front of the lens and also behind the lens.
This is a very good lens where you can do hydro implant very easily.
Yes, yes.
Yeah.
Putting visco, taking it out.
You don't need to put anything. Just hydrate all
Actually,
the
I'm
bone
telling-
and just put it.
I fast forward the lens.
for
I
the
fast forward the
postgraduates,
video.
let us be
as
safe
because
and
the
rather than sorry.
sisters took much time to give me the lens. I was a bit eighth, and that's why I put
Yeah.
some viscoelastic, and I was sitting like that.
What
and
you did is correct, sir. Go by the book.
Yeah.
There are experts here who are performing stunts. We are not talking about stunts, we are talking about driving a bicycle properly without falling and scraping our knees. So what Suben is the right man. He says put visco. As a matter of fact, Dr. Pradeep Mohanta has this habit. Anything, everything you do, put visco. Do visco, put visco.
Your,
That's how it is.
your epinucleus does not come out, put visco.
Put visco.
Your cortex doesn't come out, put visco. Methyl cellulose. No, I said put. Put visco.
Yeah. So
my surgery ends here.
yeah, it's a nice
Excellent,
surgery.
sir.
Thank you, sir.
Yeah, we can
No,
clap for
this is,
him.
Pankaj,
Sir.
this is for all of us. And I would contradict you a little bit. Like Shugato said about hydroimplantation. Actually, all lens materials are very electrostatic, and it'll just hang on to anything that you have used, and the last part is, so I load my lens with Hilon, and I
Hilon?
do, yes, and I implant hydro implantation, because the viscoelastics in the haptic will never come out.
Yes.
And that is
What is the cost of
that is
Hilon?
the first to 7. No, I prepare aliquots at the beginning, one viscoat, one Hilon will implant
Hilon GV.
10 lenses.
Okay.
Subrata.
Right.
Yeah, so nice surgery. Because of the time, we'll have a discussion later. I'll invite Dr. Yeah, sir, please.
Rudra, are you following this crater and chop in soft cataracts also?
No.
Huh?
In soft cataract, usually you can't follow any particular rule. It depends on the cataract. Soft cataract is having its own constitution.
In soft cataract, I would rather recommend Dr. Pradeep Mohanta's technique of pre-chop.
Yes, pre-chop,
Yeah,
that's a
or
good
some-
technique.
or do it somehow.
Chip and
Not
flip, it's a
available
good technique. But you can use various techniques in soft cataracts. But in hard cataracts, you have to use something that helps in breaking the nucleus.
Rudra, here we have not seen you giving intracameral antibiotic.
Yes, I have given.
You have given?
Yes.
Yeah.
Oh, means-
I've given.
Is given. So now we'll invite Dr. Subrato Mandal. See, first case we have seen, the rhexis was torn.
Sir.
Vitrectomy was done. If in sulcus we could not put the IOL, 3-piece IOL, what next? So now there comes iris claw IOL. So Subrato is a senior retina surgeon who has passed out from the RP center, and he is with me for almost 18 years he is with me. So he's a high volume VR surgeon. So now Subrat, what you are going to show?
Thank you, Dr. Pankaj. Good afternoon, everyone. And I sincerely thank to Dr. Mohan sir for giving me this opportunity. Respected chairperson, my dear colleagues, seniors, juniors. So I was asked to present a deferred surgery case about posterior iris claw IOL. It's a very short duration surgery. I think everyone should do this. So when we put iris claw IOL, when there is no capsular support, etiologies may be different. I recorded 2 cases recently because it is not easy to get such usual cases where iris claw IOL is indicated. So one is 6 days back, one is 2 days back. I have chosen the first one. The case is an 80-year-old male who presented with sudden painful diminution of vision in the left eye for first few days. There was no trauma, no surgery, but there is no lens also. So it was basically a spontaneous rupture of the hypermature cataract. There was raised intraocular pressure, corneal edema, and pupil was non-dilating, little bit of pseudo-explosion type of iris. Vitreous was mild haze, pupil was small, and I do indirect ophthalmoscopy. I could see retina is attached, but no definite nucleus was seen. Fellow eye right eye was pseudophakic with satisfactory vision. Now, this is the surgery. So in the procedure, I have to remove the lens because there was no cataract surgery previously, and it's a pure spontaneously rupture. You can see the pupillary margin, there is a pseudo-explosive material. So I do peritomy because I do iris claw lens through scleral tunnel. And after peritomy, I do cauterization of the blood vessels. Interestingly, is a retina setup. I have only monopolar cautery, bipolar cautery I can use, but this monopolar cautery only, and it gives a fantastic precise cauterization. Then pre-placed scleral tunnel before doing vitrectomy. And you can see the anterior capsule of the lens glistening surface and Descemet's fold and already there.
You have not made the entry.
No, I have not made the entry, just partial thickness scleral tunnel only. Now it is.
Yeah. Yeah, without that nothing.
Because if we enter, then I will collapse. I will not be able to put the talker. Now, as it is local anesthesia, I am doing this at 3 or 6 o'clock. AC paracentesis entry. We can put anywhere where we plan to put the iris claw, maybe vertical, oblique, wherever maybe. Now I am filling the antechamber properly with viscoelastic first. I have just learned that use enough viscoelastic. So now doing vitrectomy. Now vitreous is a little bit haze. So after vitrectomy, I was really surprised. I could not find the nucleus. Where is it? I don't know. So, but there was no history of trauma and no surgery, you know. Even with the extreme tilting of the lens under the biome, there was nucleus was not seen. But definitely there should be nucleus. Very interesting. There should be where that 80 years old nucleus is there. So with extreme indentation, I myself indented because it was not possible by assistant while doing searching for this nucleus. Now, this is the retina, and I saw it infranasal quadrant, nearly almost parts plicator region, ciliary vision, it was there. Now,
which means it has slipped through the...
Just there is a rupture and it was a small nucleus, it slipped and adherent into the ciliary region. This little, here is the nucleus. You can see this is just near the pupil is also small. Now I have, with the help of the light bulb, there was small nucleus is very small, it's very soft, idli type. Idli type. And it was hard. And what I do, I don't do phacofrag at this stage. I just use high suction of the cutter and lift it in the mid-vitreous and pronate, just supinate my, rotate my wrist. And after that, I asked my assistant to remove the biome. And under direct visualization, I just push it from behind with the help of light pipe and vitrectomy cutter, and it is rigid pupil, small pupil. And now this is this very small nucleus already because it is a Morgagian cataract and a long duration maybe. So now I do vitrectomy under 35 millimeter of mercury. At this stage, after blocking the closing the port with a plug, I'm doing it 23 gauge vitrectomy here. So I now do the AC entry. I thought it is a very small nucleus. So after AC entry, now pressure is only 10 millimeter of mercury, just to form, keep the eyeball formed. And with viscous, I thought with a little bit of increased viscous, it will come, but it did not. So I enlarged the microkeratom, and with pressing the microkeratom, it came out.
Like a slide.
So different use of microkeratome. Take a nucleus prolapse with the microkeratome now. Taken out with the microkeratome only.
Microkeratome.
Okay,
You're
fine.
just pressing the postal liquid will come.
Yeah, microkeratome used as a vectis.
Now
Okay.
Irish claw, 2 or 3 things I want to share here. The Irish claw lens is concave convex. So for posterior iris fixation, I keep the concave surface up so that there is no rubbing. And this is the previously I used to hold the IOL. It is a safer modification of IOL holding forceps. Tuck it just outside the colarity. The important is the feel of pressure and counter pressure. That is the most important thing in iris claw IOL. The pressure you give from back and anteriorly, that plays a major role because most of the time complication related to this happens here, breakage of the claw or iris TR. So this feelings comes with practice and doing multiple surgery. I put sutures, and if we do too far, it will cause inclination. There may be chances of root damage, and if it is too towards the iris margin, there will be cat's eye type features. So just outside colarity is good enough. So
In figure of 8, sir.
I do one single central suturing.
Yeah, figure of 8.
Figure of 8.
Subrat, surgery is almost getting over. I have one small question. Morning we have seen the paper where the scleral fixated IOL was used. Why you did not use scleral fixated IOL in this case?
Or
and
CMT
choose
flex.
and choose and to do the retrofixation of the iris.
See, any IOL other than iris IOL can be given CMT flex, scleral fixation IOL, glue IOL. As a retina surgeon, I have seen many complications of scleral related problem later on. Ultimately, maybe 5 years, 10 years, or even 15 years later, there is some erosion. It comes out, necrosis, glued IOL also have seen this location. But in iris IOL, maximum what happened is iris may be atrophied and one claw may be dislocated. So I can do that immediately with the nearby iris. We can just fix it, and no opening is there. So any foreign body from inside to outside the sclera is something I fear. That's why. And number 2 point is, it is a very short duration. It takes only 1 minute, not even 1 minute to put iris IOL, and other surgery is a little bit take duration.
So from the opposite side, from an anterior segment surgeon's view, I can tell this is the easiest one.
Yeah, this is the easiest one.
Cheapest one, easiest one, least time consuming,
Yes,
having good result.
So that is there.
I have two observations. One, you are using pilocut pin. The pupil is going so small, to put the lens in, it can cut through the sphincter of the pupil.
Usually it does not, rarely.
Not really.
But the other thing is, you are using a dialer.
Dialer, yes.
So, will it not be better to use a spatula?
Yes, you can. It totally depends on practice. That's why I have mentioned properly, the feel between the left hand and right hand is most important. Whatever you use, just like chopper, how deep you go, so you will damage the posterior capsule or not, how confidently, it depends on surgeon's hand. Whether it is chopper is sharp, big one, a pointed one, or not at all a chopper like Sinski Dr. Pankaj use. So it is basically surgeon's preference. So dialer is easy level, yes. I don't prefer sharp dialer. We just do a blunt dialer little bit, that's all.
Dada.
Thank you.
The only limitation of this iris claw lenses is, like Rudro said, he likes them. The most convenient option, but even in an institution like ours, keeping the whole dioptric range in an emergency situation is impossible.
Yes, it is, yes.
And my second remark is, in situations like this, I would rely on Subroto. Second procedure, it's not to be done by us.
No, that's makes sense when if you have to
because
do,
you don't do it every day.
Yes.
And the best person should
Yes, yes. We should give the best to the patient. So that makes sense. And Subrata.
Is this thing better or an iris inclination forcible or weaker?
Iris inclination forceps is safer, but we don't need any another extra instrument, so I am comfortable.
I tried with that, the dialer, I failed for twice or thrice time, and after that I was using the inclination forceps.
But dialer is very simple. I don't know, like a person like me, if you can do, like everybody can do it. So dialer is very simple. And Subrata, only one thing, if for the PGT one question is there, if we could not find out the nucleus, or probably some IOL is inside which we cannot find out where it can go. Which space? Yeah. Not nucleus, IOL. I have injected the IOL. It's gone inside. I am not able to find out. Where else you will search after doing the vitrectomy? No. Where else? In a suprachoroidal space. I had one case where my other doctor, it was Indian preloaded IOL. They injected, it is gone inside. Suddenly, Subrata was called. Then I said, okay, it is gone inside. There was a small bleed is there in the anterior chamber. Then Subrata says, okay, sir, lay out. So next OT, he did complete vitrectomy, we could not find the IOL. He tried to see, then suddenly he realized it has gone to the suprachoroidal space.
Actually, there is a potential phase if there is a iris and cyclodialysis. So with between the sclera and the iris root ciliary body, it has gone directly in the suprachoroidal. Perfect space.
Yeah, it was the perfect place. It has gone to the suprachoroidal space.
I think it has been published in IQ.
Yeah, it was published. And then we did all the MRI. Sab kuch kiya. Then we got it. Yes, it is there in the suprachoroidal space. And we forgotten about that. We put it the second IOL. Patient got 6 spleno. So patient has a two IOL in the eye and no problem in that. It was not removed. Suprachoroidal space. Where you go? Suprachoroidal is like suprachoroidal hemorrhage. Now suprachoroidal space. You have to cut from the iris, from the sclera outside and create all the mess. So IOL is sitting there without causing any problem for last more than 5 years.
There was, I don't know what it presumed, there is iododialysis, cyclodialysis. So iris, everybody choroid. Sclera and in between the choroid it has gone from the anterior chamber. It opening in the extreme inferior periphery. That surgeon can tell you.
The surgeon also doesn't know. It was a tuck. It was just forceful injection. It is just gone. No. It was a hard. It was a winter. It was a winter. It's a cold hydrophobic lens, preloaded Indian, and then they just with the jerk she has pushed and it is gone. So, yeah, traumatic cyclodialysis. They have created a traumatic cyclodialysis and gone to the suprachoroidal space. Yeah, thanks a lot, Subrata. A nice presentation, a nice discussion. Now we have, we have a Dr. Sogutopal. So now what are you going to show? He is a straightforward Phaco he is going to talk. He is not going to talk any complication.
1:30 will.
First case or the second case?
আমি জানি না কি কোথায় আমার নাম না না এখানে দিয়েছিল no intumescence actually
he did not allow patient cataract to become intumescent. He removed early.
I have a recorded video, but I thought I'll show which I have here. So thank you first of all, thank you Pradeepda for giving me this opportunity. So this is under topical anesthesia and I am doing with Centurion machine, which I feel the best machine. And my setting, because there is no overlay, my setting, the IOP was 22 millimeters. So for the PGT, 22 millimeter IOP, what is actually the bottle height? When we are using the bottle height, we measure with the bottle height, and with Centurion, we can measure with the pressure. So 22 millimeter is about 30 centimeter bottle height. So it's almost at your level. And my vacuum was 475 and aspiration rate was 26. So I'll start the Phaco. So just watch what I do. I don't hold the eye at all with any Johnson's bird or anything. It depends on the patient's cooperation. So minimal touch. I've done the side port and I'm doing the other side port as well. And now I'll be putting visco or I'll do the incision depending upon the patient's thing. Oh, it started recording quite late actually, sorry. I've already done the section, and what I do with section, with the keratome I leave the flap, and with that flap I do the rhexis. So that part is not recorded somehow. So I try to keep a rhexis of about 5.1 to 5.2 millimeter of mercury, 5.2 millimeter. Once the rhexis is done, I'll just fast forward. So this is Haldipurkar's faucets. So once the rhexis is done, I keep it slightly small so that there is perfect overlapping. I'll be doing the hydro dissection. Hydro dissection is better done after letting some visco out, and then do the hydro dissection, and you inject in small pockets and tap the nucleus down so that there is no posterior capsular blowout. So once you have done that, then you can rotate the nucleus with the cannula, or you can rotate the nucleus as I do with the chopper. So I'm putting Phacoemulsification Plus, as Rudra has done as well, because it's under topical and it's for the patient's comfort. I'll just forward it. And if you look, inserting the side port, you have to be careful with the chopper. Now I am doing direct chop, so bury the nucleus and chop the nucleus. Is probably grade 3 nucleus. So
you brought your chopper along with you?
Yes.
Because if I remember correctly, Dr. Pradeep does not have a chopper.
Yeah.
No, he has a chopper. He has different kind of. He has so many choppers are there. Yeah, a lot of choppers are there, and it may be different kinds of chopper is there. So he's comfortable with some chopper. He brought that.
Yeah. So So again, this is direct chop. Hold the nucleus, bury the nucleus, and separate with the sharp pointed chopper. Rotate. I do as many small pieces as I can, so that it's taking out is easier. And I do patellar chop as well, where the central beat is left over. এটা কত grade 2 হবে 2-3 হবে So these are the phacos, these are the nucleus which are easy to chop, has the right consistency.
So what is your setting for the chop?
Chop setting, as I have shown, 22 millimeter mercury, 475 vacuum, 60 torsional phaco, no longitudinal phaco, and 26 aspiration.
26.
There was some problem with recording actually.
Yeah, it's okay. We could fast forward.
Yeah.
Fast forward kar
Yeah. So once I have done the chopping, I'll take the nucleus pieces one after another. And we have to be very careful when taking the last piece out. There was some chamber fluctuation.
And especially if you are using the low height, low IOP. So
now I have shifted to epinucleus mode and removing the epinucleus. And then visco was not ready again. I had to come out and wait for the visco. So once I've done the visco, I had to extend because I am using a Swiss fob lens which goes through 2.8 millimeter. So I have extended the wound slightly. Doing the IA, when you are doing the IA, hold, swipe sideways, then pull it in the middle, and then with the help of the side instrument, you use it. I do always do my IA with my left hand because I do hydroimplantation, which was exception here today. I do my IA with my left hand, irrigation with my right hand, because when I swap over, my irrigation cannula comes to the left hand at the end so that I can do the hydroimplant. So I do my IA with my left hand, as you can see here, and then I'll swap over my hands. And Pankaj actually has inspired me. Now I sometimes do left-handed phaco as well under inspiration of Pankaj. So once that is done, now I swap over. Just fast forward and do the eye. But now when I was asking for the lens, I was told that I have to load the lens myself. So I'll just put it forward. Yeah.
Next time you do IA, you start with the side port. Next time you start your IA.
First do the incisional.
Sub. Yeah, basic.
Sub side port.
Yeah.
Sub side port area you do first, you not.
Yeah, basically in seasonal, what sir said, because you have already used the viscoelastic, some amount of viscoelastic is already there. So if you do the IA from the sub-incisional area, it becomes easy. Because in the last, if you say viscoelastic has come out, then the chances of getting AC shallowing is much more if you just manipulate with the section.
And another matter, there's nothing wrong in injecting visco 2 times or
yes,
even 3
nothing
times
wrong,
during
nothing
IA.
wrong, nothing
So,
wrong.
so you are saying to do this area first?
Yeah, sub-incisional.
Using your left hand.
Yeah.
So the left hand sub-side port.
Sub-incisional.
Sub-side port area. For which
See, we have learned since beginning.
This area. You are meaning this
Yeah,
area?
this area, yeah.
But that will be doing with my other hand anyway.
Yeah, it's okay.
No. Yeah, I have to inject the lens. So,
Take it,
yeah.
take it. So
that's
basically,
why,
yeah, if you're using coaxial,
Yeah.
sub-incisional if you remove, that's easy actually. So that's what the concept,
Yeah.
what
Because
sir was
I'll be
mentioning.
doing that with my other hand. So that's the thing now. I'll be loading the lens. I'll just fast forward this because I had to load the lens myself. And then I'll be injecting. I'm using a screw injector, which is very controlled lens delivery. It doesn't shoot out. It doesn't go to the suprachoroidal space.
You
Only
mean
problem
this is
with the
Swiss
screw
phobe?
injector is
This is
screw
a Swiss
injector.
phobe.
Huh?
The IOL is a Swiss phobe.
Swiss phobe.
But that comes with its own injector.
No, they didn't have. So they gave me a butterfly cartridge.
So you can use any injector.
Okay.
Yeah, so you have to put the lens.
Yeah.
You should know how to put the lens. So that's okay.
Yeah,
Injector
so
doesn't make any difference.
Yeah. So
Yeah.
once the IOL is in the bag, I am doing the removal of the visco and wound hydration, and to finish up my case.
Yeah, excellent surgery. So Pradeep da, any comment from your side? You have not spoken anything.
As he said, today is his daughter's wedding.
See, I don't bother about chopper actually, whether it is blunt chopper or sharp chopper or whatever, it is Sensky hook. I just use the handpiece in such a way that any chopper can manage the case.
Sir, one question. Do you think in your submarine chop technique, do you think that sharp chopper will help a bit as because the core of the nucleus is thicker and
You are going till the end of the hard part.
Basically.
You are going through the substance of the nucleus almost near the opposite equator, and then you are using either a Sensky hook or a chopper, whatever you use, you can crack.
Yeah.
Yes, with the Sensky hook also you can
Yeah,
manage.
Sensky hook also, because I don't use chopper, I use Sensky hook only for all the cases, whatever is there. Devasita. Any comment?
No, I can't, Pradeep, agree to you.
Yes, everybody has his own technique.
Because, yes, like if we go back to Sudeep's case, he
uses
did
very few
a
instruments.
big trench. He sculpted
Crater.
the nucleus. That's the way he does it. But then he saw that he doesn't have a sharp chopper. And that time,
Yeah, especially
you
live
can't
here.
go much behind. So that's the problem, and you don't have areas to chop well. So maybe sometimes he has chopped the capsule.
Even at the level of the rexus.
Yeah, I mean, so the techniques that one follows, so you have to go by only one chopper.
That is something. See, you have to learn and you have to follow the technique. What is working best in your hand?
I would like to differ from.
I have a small
Pankaj.
suggestion about
Yes.
chopping. So I do a lot of
Alada,
I do a
next
lot of
up.
direct chop. So when you take your chopper, you score the nucleus actually from the center
Scratch
to the
on the
side,
surface and
so that you're well under the capsule. You're well under the capsule, so you score it like this, and then you're doing a direct chop, all right. But you score, so you're scoring over the superficial cortex and epinucleus, so you are well below the plane of the capsular axis or the anterior capsule. So there is no way you will injure it.
Agreed. But here's one lesson for the postgraduate students, which I learned from my teacher, Dr. Purnananda Mishra. He said, you should become an expert where you can do anything with any instrument. But remember, there are specific instruments for specific activities. So that is one thing which there are
Yeah, you should know which instruments work best in your hand.
So what my professor said, I will share with you. There are specific instruments for specific activities, and you should know how to use it. Of course, after 10 years, Dr. Sudip Das will say, there are specific instruments for specific surgeons, which is the next level of development. Agreed.
Now he's working for 30 years, man, not 10 years. So now we'll invite Dr. Maleta sir to just show how his technique works, and let's see how different he is doing.
Welcome everyone. Myself, Malaida, surgeon of dinosaur era. Podir has given the opportunity. I'm the surgeon of dinosaur era. I'm talking. This is the first life surgery. I'm using the Centurion Gold. I'm not so energetic and heroic, just Sugoto. I am doing the pressure of 40, height of 54 centimeter. I am using the side port of Alcon 2.2 approach.
Pankaj, this is that 1.2 MVR.
Yes, yes, that's what the 1.2 MVR. Well, actually, yeah, it is not needed, and it has a 1 millimeter as well as 1.2 millimeter by Alcon. If I'm not wrong, he's using the Alcon one. 1.2 both works. That's fine.
If you pay the paisa dile kharcha pay jabe arki. Just I've taken the help.
The only problem with the Alcon blades, it can be used only once.
But we are Indians.
No, only once for during the surgery.
After that, it does not work. I don't know.
Because it's got a Teflon
Dr.
coating.
Sudip Das is our Alcon. What is
it's a Teflon coating.
He says Alcon, the problem with Alcon is you can use it only once. I said, but we are Indians.
Alcon what?
Alcon MVR blades.
Oh. I use any blade once.
No.
I'll use any blade once.
That is fine. Like what
Is it
happens is
2.2?
Do it like, you do one side port.
Yeah.
Suddenly you decide I'll do a bimanual.
Yeah.
Then you go to do the second port, side port.
Yeah.
It won't work.
Yeah.
It won't work. You got my point? Yeah. Suppose you say, just decide against coaxial, I'll go bimanual. You can't do another port.
No, he said vodka.
You can't even spell it.
As it is, I can't stop talking. After vodka, that's the end of the story. In Russian. Hey, Prasenjit, as it is, mic is not working. You want to have vodka?
No, 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 no.
What was the flow rate and
Yeah, what was the parameters in the Malada? What was the parameters in this case?
40 flow rate is 40.
normally you don't see these pieces flying
40. 40.
So that's because there's no visco in the AC.
No, no, no.
Ah.
You don't have visco will anyway come out, even if you put.
How long it is? Now everybody is using bimanual. Nobody is using coaxial. Very bad.
See, whatever techniques we learned from Dr. Sudip Das. He uses bimanual IA, so we are also using bimanual IA. But Dr. Pradeep Mohanta sir, you use coaxial, bimanual.
He uses Simco.
Simco.
I am the only one probably still using coaxial.
That's because in Shankar Netrajyoti,
Yeah, I got trained with that, and I am very comfortable with that. And I make only 2 opening, no 3 opening. Yeah, we just make 2 openings. No, Sudeep was asking a question as to why the fragments were fluttering.
Yeah.
Right?
The lens is supraphobe, but I am using the Alcon cartridge.
Right.
Yeah, it's a good
I'm very comfortable with the Alcon cartridge.
With the Monarch injector.
Yeah, Alcon cartridge. That's where we
C
say.
or D, sir? For
C.
supraphobe, for Swissphobe, it should be C only. C.
Actually, that's a beautiful cartridge, and any lens you can put with that cartridge.
Yes.
With the Centurion, actually, you need an absolutely water-sealed
Watertight.
eye.
Yeah.
That is a very fundamental requirement.
Agreed.
Because
Otherwise, the sensors don't work properly. And that was one reason why there was some surge when you were using the Centurion. No, who was using the Centurion? You were using the Centurion, and there was some.
Using 25
So that's your favorite number? 25?
Yeah.
You're comfortable with that? What do you use, sir?
I use Radley now.
No, not that. When you were using Centurion.
Yeah. Basically, yeah. Sir, Balada, what is there? We are behind the lens, we can see something is there. Some white things are there.
that is the Monarch injector.
Yeah. What is there? Anybody from the postgraduate? Some white thing is sticking
An
there.
Alcon cartridge was used to implant an IOL. Any cartridge. Okay.
No, Alcon cartridge. Let's be very.
Yeah. See, any answer? Some white thing is sticking there behind the IOL.
But it won't affect vision.
Yeah, little bit. Balada, थोड़ा सा पीछे कर ले.
You can carry on.
Yeah, चालू कर दे दिख जाएगा. Yeah, just continue.
and click on
Play, Balada.
What is it used for and what is the material?
Yeah. Yes, that's what the white thing.
It's Teflon.
No.
It's a lubricant.
Glutamine monostearate.
It's a lubricant.
Yes.
So basically,
What? Glutamine?
Glutamine monostearate.
Monostearate.
see, we can see that white thing is sticking. Basically what sir did, he put it the lens in a Alcon cartridge. One thing is very important. These cartridge, apart from Alcon lenses, if you use any other lenses, you will have this kind of white thing is much more.
Absolutely.
So if you are using any Indian lens with the Alcon cartridge, you have to be careful this thing. Yeah. So that's a cartridge is different. It's the same thing. If you use with the J&J cartridge, you will never see this kind of thing. So there is a problem. There is a difference in the Alcon cartridge. Any hard lens, Alcon lenses are quite soft lens. If you use any hard lens in that cartridge, you will see one white sheet of things sticking behind the IOL is there. So 2 options are there. You can remove also this. you can remove this. You can use the hydro cannula. Just do the hydro cannula. Sometimes if we really get stuck, even I have just put it anteriorly, and with the forceps, Uttarata forceps, I have taken it out. Yeah, so no, it can sometimes, it can stay for the long time. So it is very...
if it is behind on the posterior surface, trapped between the PC and the IOL, it stays for a long time.
Long time,
If
yes.
it is anterior, it goes
Yes.
away within a day or
Anteriors
two.
are very easy to remove it. Problem is the posterior center thing. And since, this is what very big problem.
Okay.
Yeah. So now we'll have Dr. Vikram. Vikram, aja.
Before that, Dr. Pradeep Mohanta, thank you very much for being a wonderful host. The time has come for us to say goodbye. We have to go to Calcutta to catch a flight to Chennai. So ladies and gentlemen, it was a great pleasure being with all of you. We had a great time with you. Goodbye.
Chaliye sir, Sai sir. But you have a beautiful memory, you remember that. Thanks a lot for that.
See you, sir. Pleasure meeting you.
Dada. Yeah. So now once Vikram is getting ready, Vikram, what is your case?
There are two, Dr.
Dada. Yeah, thank you, sir. आज के So I'll invite Dr. Vikram to do the phaco. It seems to be hard cataract. Vikram, what is about the case?
It was grade 3, 4 के बीच में.
Okay, grade 3 plus
So,
cataract.
Thank you so much for this opportunity, sir, and I welcome my juniors, my colleagues, my seniors. So before I just start this surgery, let's when we learned phaco, I remember Dr. Debashish Bhattacharya was there, in some live surgery thing. He said one step follows the other. So a good incision followed by a good rhexis, followed by a good nuclear dissection, followed by a good phaco, etc., etc., etc. And after doing plenty of surgeries, I have felt that the most important step in a phaco surgery is the nucleus dissection, the nucleus rotation. If your nucleus is free, you can actually get away with a lot of things. So this was a surgery we did in the morning, and this was my debut live surgery somewhere outside my home center. So I was a little scared also, and so this was okay. Now I am a little different. This is my side port. I use a 2.8 side port. I don't go all the way in. This is my main port. The knife was a little blunt at the tip. You can see the tip was a little bent.
You see temporally?
No, this was, I was at the head end.
Okay.
And this is my side port from which I use my chopper. So it is diametrically opposite the other side. So I did all my ports with the same blade. I was saving some money probably. And one blade.
Yeah, that Devashish is very happy with that save one
Sir,
blade.
One blade and
he saved a lot of money with that.
Sir, as you said, sir, with that one blade, especially the Joja blade, we can do a lot of surgeries. Screen.
See, the finances, what
And by the
Devashish
time
can
the screen comes on, I would say that the videos, especially for our juniors, the videos we see of these surgeries, these are very important. We have especially the unedited videos.
The other thing about doing ports like this, if you actually master it, they are triangular where you don't do tissue damage at the corneal level when you are chopping or moving your instrument because it's a triangular thing.
But you should not become very big, so you have to be very careful. So it's not for the beginner.
The hand control, sir, has to be there,
head control has to be very good.
So,
Yeah, yeah. That's what Vikram will show.
So we'll go forward. This was the Rexis.
Yeah,
We
that
go to
was
the Rexis. So I use a cystitome which was probably made by Rudro. I did not make my own. It was your cystitome.
But one
probably.
thing is, Rudra makes good cystitome.
Yes. And we take out the anterior capsule.
Okay.
And this is, I feel, the most important part. You can see the fluid wave going back. This was actually...
Beautiful hydro, yeah.
This was actually Shuvenda's, I remember, he would always say fluid wave, fluid wave, fluid wave. So I just do that. And this, I feel, is the most important part of surgery.
How do you do that?
Yeah.
How do you do that? How do you get that?
Yes. Let it go. You just say answer. How you do the hydrosection? इसको चलने दो.
Oh.
हाँ, इसको चलने दो. Yeah.
Okay. So
yeah.
oops.
Boss. Chair देंगे. लगा नहीं ना? Hey, बैठ. It's okay.
I did not know my video was so powerful.
Yeah, and Suguto. Chair ही भेंगे दिए चो. हैं? चलो, आ जाओ.
So the question I would come to Shwenda said that I normally do my hydro from one side. It's normally from my left side. And if I'm doing an SICS, I start my hydro from 12 o'clock.
No, I think what I wanted to convey was, when you do a hydrodissection, go under the capsule. Actually,
yes,
inject a little before your shot of the capsule. You create a plane, and then you take the hydrocannula and stick it to the back of the capsular annulus of the anterior capsule, so that you're absolutely flush with that capsule. Now, when you do a hydrodissection, your cortex completely peels off, and actually you don't have to do all that, rotation of the nucleus. So your cortex comes off absolutely.
But don't do it so vigorously in a small.
Perpendicular to the equator.
No. How do you do that?
What?
Like whatever you describe, you have to burp out a little bit of viscoelastic.
We have to tap. That's what I did.
Yeah, like many people don't do it.
Yeah, so you need to create the space.
Immediate step before was the Rexis, so you had filled it up with visco.
And if you have a small...
Before I start off with the hydro, I forgot
you
to
burp
mention,
out some visco.
I take out some visco from the anterior chamber. We reduce the pressure in the anterior chamber. Now once the hydro is done and the nucleus is mobilized, then I am a lot more at peace.
One more thing, if you have a small Rexis or if you have a torn Rexis, you have to be very careful in this situation.
Now, I am a little thing about my chopper. This has been a chopper story. So I use a blunt chopper. And my method is slightly different. If you see, I go into the nucleus and so I go into the nucleus. Right now I'm taking out the superficial cortical matter. Now I can see the nucleus surface. I go into the nucleus, I tilt the nucleus. I can see the edge. I go behind the edge with my chopper.
And tip is always below?
Tip is within my visibility usually.
Okay.
Unless the pupil is very small.
Yeah.
Now I come back from the behind and I chop the nucleus.
Yeah, this is how the blunt chopper and the direct chop. Direct chop with the blunt chopper.
So then
excellent.
Then it's simple.
Yeah, blunt chopper, direct chop has to be done like this. Beautiful. Yeah.
So then a routine, I broke it into a few pieces. I don't remember how many, and as many as I can.
So make the pieces small so it can come out easily. Yeah.
So this was the
Rexis size.
Sir, I did not measure.
But roughly around 5.5. That's what looks like. Yeah.
I actually did a larger, slightly larger
Yes.
rexes than I usually do because this was a new place and I wanted to be a little safe.
In larger rexes, it can go somewhere
And
else also
I don't-
sometime. You have to be
mean,
safe.
Regarding the machine settings, I use the same setting which Dr. Mohanta uses. I just said, give me a peristaltic
It's Otley machine, if I'm not wrong.
Otley Ferros.
Yeah, it's Otley machine. Beautiful machine. Yeah.
Now, once the nucleus fragments are out, since the epinucleus has been dissected well, it usually comes out as one piece.
Your tip is
Usually.
always facing down.
Downwards,
Is there
yes.
is there any specific reason or?
No, I am more used to facing downwards or sidewards.
Okay.
So
But
this
the
is
basic teaching is not that. Basic teaching is the tip should face upwards because you should see. See, he is an experienced person, he got his own technique, but everybody should start, the tip should face upward, not the downward.
There is a reason for that.
Yeah.
The scientific reason is the cone of power is from the edge of the tip, bevel down, bevel up, the bevel up, and from the tip, the cone radiates downwards. It doesn't go upwards. So if you do bevel down, you are actually losing a lot of energy. So that is the science. But
Actually,
I know you can do it any
what
which way
I
you want because you get a better occlusion over here.
I get a better occlusion.
Yes, you
That's
get
what
the
I
better
want,
occlusion.
because I get more surface to hold the nucleus. Now comes the little bit of a controversial part where I do not use an IA. I do not use a thing. I use a Simcoe.
That's fine. Yeah, it's
I am very comfortable with the Simcoe and I prefer to use it.
fine. Fine.
That is why my side port
Is
was
slightly larger.
slightly larger than what it should be. Usually it never leaks. I mean, till date I have not found a leaking side
So you
port.
use Simcoe with a syringe or with a irrigation, normal irrigation?
No, with a 5 ml syringe. Earlier we used to have glass syringes. Now we use the
Plastic
disposable, the Dispovans.
What is the size of the Simcoe?
It looks
Probably
thin.
22.
It looks
I
a
did
little
not
bit thin.
see.
Yeah.
I'm just curious.
so they
I'm
give
just.
me what-
I've
what we
always
use.
been curious. Why would Pradipda or Vikram always use a Simcoe, and why have you not moved to a I?
So I tell you why I use a Simcoe. The simple reason is A, it is fast. I am much more comfortable with it.
Comfortable is nothing. It's not faster.
No, I am comfortable, so it's fast. I can drive my
People
car
who,
very easily.
Shubhen, people who use Simcoe have done a lot of SICS.
Yes.
I
One
have.
more thing.
I have
Right,
myself used a lot of Simcoe
They
because I
use
did
it
ECC.
by habit.
I did ECC. So
See, that some
And
people still
ECC.
use coaxial, man, so don't
And
worry
also
about that.
ECC.
ECC. And we all learned ECC first.
Yes,
I mean,
continue,
I'm the last generation.
continue,
who-
continue.
Oh,
चालू रखो
हो गया
उसको
खत्म
बंद नहीं
हो गया।
करना. Surgery, हाँ, lens डालो.
actually, someone whom I heard early in my career said, if you want to start Phaco, start doing automated IA first.
Yeah,
So
because
now-
closed chamber, yeah, fine, it makes sense. ठीक है.
So we put in a Hoya
Which-
single piece.
Yeah, side port से cortex lever. ठीक है, वापस आ जाओ. यहीं पे बस. Yeah.
Wait a minute, just a minute.
No, बस यहीं था और आगे. ये. Yeah. Easily comes out. Yeah.
It comes out very easily. And
Yes.
as you say, as you know, the radial movement is.
It's a lot
You
easier
can
than ACC because you have got a closed chamber over here.
Your chamber is always usually maintained. So this got, I mean, this was a very small bore Simcoe because it was getting a little, clogged. And yeah, now we can take it out from the side port. Oh, this was a piece which was kind of
Yeah, it's
a bit of a nucleus piece.
nucleus, epinucleus kind of
so
thing.
I
Yeah.
had to tap it and bring it out.
Yes.
For the 12 o'clock, sir.
Yeah.
Can you make only one side for only the left only till large?
Yes, sir, I can do that with the right eye, not with the left eye, sir.
That's why you should do left eye with left hand.
So this is with a side port, and it came out in one go.
Beautiful. Excellent. It's very easy and very simple. At least initially, like when you're during the transition from SICS to the Phaco, if anything is there, Simcoe is a very good thing. Nothing wrong in that initial stage.
No, we do use, for example, if I'm using a toric IOL, then...
That's not a question. I was just curious if it had gone.
Yeah. Which lens is this?
This was a Hoya single piece, 150 probably, 150, Hoya 150.
Okay. Hoya single piece hydrophobic lens.
Hydrophobic lens, and
It was
Hoya is absolutely...
Yeah, preloaded is, yes. Nanex maybe, Nanex. It looks like Nanex. Excellent surgery, Vikram. And it was your first surgery outside. Everybody should clap for him. It's excellent surgery. Great.
No, inauguration.
Yeah, so now this session is over. Now we'll have an inauguration session. We'll request Pradipda to invite our guest for the inauguration.
Yes,
Hey, Babu, light ta jala.
welcome again. And the mission of my life is to teach the students the surgical aspect. That's why every year we try to organize a live surgery session just to inspire the students, PGTs, senior residents, fresh surgeons, those who are learning surgery. Through this, in one day you cannot learn surgery, but you get some inspiration and keep the efforts on and become good surgeons in course of time. We have with us Devashish. I consider him my guru and my mentor. He is the person who told me Barakpur is a good place, Ranaghat is a better place. Pradeep, go to Ranaghat. You will get patients. Most important thing is you will get patients. If you stay in Kolkata or somewhere near Kolkata, you will not get enough patients. That was a very good advice for me because I love work. I love to do lot of work. And I came here and I get a good number of patients. The key to become a good surgeon is that you have to get a certain volume. If you do only 5 surgeries in a month, you are not going to increase your skills. Maybe you have to do 5 surgeries in a week, at least. Then you develop your skills. So fortunately, I came here and I started my practice here in an optical shop, and then in a rented place, and ultimately we are here. Thank you, Devashish. Without your advice, probably I was thinking of staying in Barakpur or Kollani or somewhere. But Ranaghat is a better place. That came from your mouth. Okay, we have with us Paragdai. He is my mentor in getting votes. He was supporting me from very beginning to get votes in and to be the member scientific committee. And thank you, Dada. We have with us Shugato. Shugato actually my friend. Shuven and Pankaj, Dr. Manopal. So I invite all of you and light the lamp and inaugurate today's meeting. Please come.
ও সে স্বপ্ন দিয়ে তৈরি সে দেশ স্মৃতি দিয়ে ঘেরা এমন দেশটি কোথাও খুঁজে পাবে না তো তুমি সমর দেশের রাজধানী আমার জন্মভূমি
Of গেলে তড়িৎ এমন কালো মেঘে
তার পাখির ডাকে ঘুমিয়ে ওঠে পাখির ডাকে জেগে এমন দেশটি কোথাও খুঁজে পাবে না গো তুমি ও সে সকল দেশের রানী সেজে আমার জন্মভূমি সেজে আমার জন্মভূমি সেজে আমার জন্মভূমি এত স্নিগ্ধ নদী কাহার কোথায় এমন ধূম্র পাহাড় কোথায় এমন হরিত ক্ষেত্র আকাশ তলে মিশে
এমন ধানের উপর ঢেউ খেলে যায় বাতাস কাহার দেশে
এমন দেশটি কোথাও খুঁজে পাবে না গো তুমি ও সে সকল দেশের রানী সেজে আমার জন্মভূমি সেজে আমার জন্মভূমি সেজে আমার জন্মভূমি পুষ্পে পুষ্পে ভরা সাখী কুঞ্জে কুঞ্জে গাহে পাখি
গুঞ্জরিয়া সে অলি কুঞ্জে কুঞ্জে ধে
তারা ফুলের উপর ঘুমিয়ে পড়ে ফুলের মধু খেয়ে এমন দেশটি কোথাও খুঁজে পাবে না গো তুমি ও সে সকল দেশের রানী সেজে আমার জন্মভূমি সেজে আমার জন্মভূমি সেজে আমার জন্মভূমি
ভাইয়ের মায়ের এত স্নেহ কোথায় গেলে পাবে
তার সঙ্গে হাত লাগিয়ে দাও
হ্যাঁ আমার হাত লাগাতে হবে হাত লাগাতে
গোল্ডেন হ্যান্ড
हाँ फोटो हो गया चलो हाँ हो गया अब छोड़ दो
थैंक यू
You tell them.
There is one thing I forgot to mention. We have read a quotation, better is your own path, though imperfect. than another's well made. I would seriously suggest all juniors to see the videos uploaded on YouTube, especially the unedited ones. I have learnt a lot from them. I have learnt hugely from them. Dr. Mohanta's videos, especially because they are not edited, and it's not that he's showing only good cases. He's also showing those cases which have complications, and that is how we learn. Because as I remember, Dr. Bhattacharya once said, a big surgeon is the one who can manage complications better than the other fellow. Sir, I'm quoting you. So, I feel that you should do the videos. Those are really important.
Thank you. And every year we want your presence and Banglaয় বলে পদধূলি at NETRAJYOTI. And now we are going to start faculty talks. First, we have Debashish Da with us. It was in 90s when Disha was not there, when we were only doing surgeries in small centers, mainly ECC. And whenever we went to conferences, national conferences in different places, we would see that so much development, particularly in South, so much development in ophthalmology. We go to North and see, and in conferences, so much development. They are doing so many things. And in our state at that time, there was actually nothing. No vitreoretinal work, no corneal work, nothing was there. We used to sit with our head down, and we were feeling very inferior. And nothing is there in our state. Then Debashish Da thought something and started Disha. And we reached somewhere. The tendency to go to south decreased, and a lot of good services started, particularly corneal services, keratoplasties, DSEC, etc. Phacoemulsification, SICS, everything started at a large scale, publications, and we felt proud. Debashish Da, we are really, I don't have words what to say. You have made us proud, made Eastern India proud with your thoughts, with your work, with Disha. Personally, yourself, I have worked before Disha came. I was with you for maybe 6 months or so. I have seen your ideas, expanding ideas and how it works, but we could not absorb it much, but still we feel proud that Disha has done something in West Bengal. And not only in West Bengal, it's a name in India and abroad. So, Debashish Da, please tell us your story, how you would change the situation in Eastern India.
I think everybody here has heard about the Disha story. I think many a times we have told the story here and there. Pradeep has said about the dreams. No, dreams are important because, if you persistently and consistently and resolutely dream, it will happen. And why this happens, I don't know, but it happens because you keep on sharing with people, your friends, your peers, and many think you are mad. Many get bored of you. They, try to run away from you. But a few hang on. So, so that's the power of dreams. You will always hear the Americans talking about dreams, the big American dream. Now, dreams, I must not claim, that, oh, I'm a dreamer and I had to execute, and so Disha came up. Well, much in life occurs more by default than by design. So essentially, in everybody's life, if you go to any autobiography you go through, if you read carefully in between the lines, you will see there are some things which have converged, but probably the only things that helps is one, being straightforward to a particular aspect of thing, and the second thing that helps is resilience. You have to bear through and pass through hard times. So, when I was your age, we passed out MS, and of course, we had wonderful teachers. I think a few days back in Debashish Boiragi's place, I gave Professor P.K. Chatterjee oration, and there I talked about my professor, Professor Chatterjee, and eventually I did my MS, another big stalwart of our times, Professor I.S. Roy. So you can well imagine those days. Just to get into you and those times, when somehow I stood first, I don't know how, but that was the first time that we could choose under whom we can do our post-graduation. We had a choice. Now, before that, it would be an interview, and there were all the professors would sit who are entitled to take postgraduates. In our time, there were only 8 seats, 6 open and 2 for the service candidates. So, because I talked, so I asked my Professor P.K. Chatterjee, কোথায় করব স্যার? তো বলে আবার কি এর মধ্যে কোনো চয়েস আছে নাকি? I.S. Roy, Mrinalda is here, Paragda is here, so they can recall those days. You cannot actually imagine the magnanimity of that person. Like there were always 15 people surrounding him, and it was very difficult. Like as a postgraduate, the first day when I went to him, because I signed, so I had to go. I was supposed to join on a particular date. So then I was standing. I wished him good morning. Said, "Na tomake chinlam na to." I said, "I'm the new PG. My name is such and such." Oh, হ্যাঁ এখন তো তোমরাই ঠিক করে নাও কে কার আন্ডারে করবে. So that was his immediate reaction, and then he just went away. And so then I asked, I knew a few, Joduda was the RS, and what to do. Pannada was there. Ki korbo? And he said, ঘুরে বেড়া পেছন পেছন. So for 7 days, and he used to come exactly at 7:45 and leave at 3 o'clock. 7:45, the PG had to open the door of his car, otherwise he wouldn't step out. So it was a white Ambassador, WME. So 7th or 8th day, and I was absolutely clueless. I just didn't know what to do. And I got scared, like I used to hear some people have not completed their you know, the thesis was never signed, they couldn't finish their MS. So I said, is this my fate going to be? But then everybody said, no, 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 keep on going. Then on the 8th day, I was there. Every day I used to stand in to receive sir. So then somebody had come to open the door. He just, from within the car, he said, hang on. And then he showed me, come, open the door. So yeah, privilege. So then the moment I opened the door, he came out and he said, ki khub feudal lagche, ব্যাপারটা খুব feudal লাগছে যে দরজা খুলে দিতে হচ্ছে স্যারকে। তো মানে just he said one word, খুব feudal লাগছে। I mean, no, sir, I come from an ordnance background, defense background, so I'm used to this. It does one thing. It ensures that you come to the department before I do. So there were simple lessons like this. So administrative lessons. Like one day he asked me, ki, আচ্ছা নিচের ফোনটা ঠিক আছে, ওয়ার্ডের ফোনটা ঠিক আছে। সো অ্যাকচুয়ালি ওয়ার্ড ওয়াজ নট মাই পার্ট অফ দ্য ডিউটি, ওপিডি অ্যান্ড সার্জারি ওয়াজ মাই পার্ট। সো আই কুডন্ট আনসার হিম, অ্যান্ড দেন ওটা তো তোমার, ওটা তো তুমি দেখো না। অ্যান্ড দেন উই স্টার্টেড ওয়াকিং টু দ্য ওয়ার্ড, অ্যান্ড দেন শি কল্ড দ্য সিস্টার। He called the sister and said, একটু ফোন করুন তো যে ডক্টর পান্নালাল শাহ এসছেন কিনা। তো she went away. Now sir said, আমাকে বলছে যে এখন যদি ও ফিরে এসে বলে যে ফোনটা ঠিক নেই, I'm going to strip her off. Because she is on duty and if she doesn't know that the phone is right or not, চলে গেছে মানে ফোনটা ঠিক আছে। So she has committed. Now if she comes and tells me, then I'm going to fix her right. তো পান্না এখন আন্দামানে আছে, আই ক্যাম্প করছে। So he knows that he won't be there. তা বলছে পান্নালাল শাহ এসছেন কিনা নিচে ফোন করে দেখো, because it was almost 9 o'clock. তো sister came back, স্যার ডক্টর শাহ এখনো আসেননি। তো ও আচ্ছা ঠিক আছে। তারপরে আমাকে বলছে, আচ্ছা তোমাকে যদি বলতাম তুমি কি করতে? স্যার আমি জিজ্ঞেস করতাম যে ডক্টর শাহ তো এসেই যান এই সময়, কেন আসেননি? তাহলে তুমি পুরো উত্তরটা দিতে যে উনি আন্দামান গেছেন, তা স্যার উনি আজকে আসেননি ওই জন্য। বলছে হ্যাঁ, কারণ তুমি পান্নাদাকে খুব ভালোবাসো। এখন এই দিদিমণির সাথে পান্নাদার কি আছে আমি কি জানি। So you know, he was, and he used to teach little things like this. And like we were discussing how teaching should be, he said, when I joined him on that 7th day, opening the door, feudal system, and then he said, এক মাস আমার পেছন ঘুরবে, আমার পেছনে থাকবে, কারুর সাথে কোনো কথা বলবে না, কোথাও কিছু লিখবে না, জাস্ট আমার সাথে থাকবে এক মাস। And within 1 month, because of the size of the operations, 400 পেশেন্ট ওপিডিতে, 40টা 50টা ওটিতে পেশেন্ট, ওয়ার্ড এটসেট্রা, you learn ophthalmology in 1 month. So part of the teaching was like, একজন তখন যেটা খুব কমন মিস্টেক হতো যে আইরাইটিসে গ্লকোমা ট্রিটমেন্ট, গ্লকোমায় আইরাইটিসের ট্রিটমেন্ট, ভেরি ড্রামাটিক্যালি ডিফারেন্ট ট্রিটমেন্ট, কারণ সব টর্চে দেখে এই করতো। কেউ একটা ভাইটামিন লিখে দিয়েছে, প্রেসক্রিপশনে আছে, ওটা প্রথম লেখা হলো ওই ভাইটামিনটা। তারপরে অ্যাট্রোপিন বন্ধ করে পাইলোকার্পিন দেওয়া হলো, ওপরে যাও, ওপরে নিয়ে যাও, ম্যানিটল চালাও, পাইলোকার্পিন দাও, তারপরে প্রেশার কমলে পিআই করো। হ্যাঁ হ্যাঁ ছিল, হ্যাগস্ট্রাইটের একটা স্লিট ল্যাম্প ছিল। হ্যাঁ, only I had the access because I was IS Roy's house staff. আজকে অরূপ চক্রবর্তী থাকলে, আমার ব্যাচের কেউ থাকলে শেয়ার করতে পারতো। হ্যাঁ হ্যাঁ, ওটা স্যারের ঘরেই থাকতো। হ্যাঁ, একটা RRC-তেও ছিল, দুটো ছিল। So I also finished my RRC fellowship there. So we were coming to stories, আজকে গল্পই করি। তো তারপরে MS চলছে এরকম সময় I went for a government interview. তখনকার দিনে আর কিছু ছিল না, সরকারি চাকরি ওটা পেতে হবে, কারণ everybody will agree, পরাগদা, মৃণালদা, because practice were for elites like Professor I.S. Roy. মানে আমাদের মেডিকেল কলেজে যদি 12 জন প্রফেসর থেকে থাকেন, তার মধ্যে 3 জন প্র্যাকটিস করতেন। প্রয়াগ মণ্ডল, তোমাদের প্রদীপ দা, ডক্টর প্রদীপ মহান্তর বস, একদিন আমাকে ডেকে বলছে, এটা কি লিখেছে প্রদীপ, ও একটা এত বড় কারিকুলাম তোমার মতো, লাইক what is how medical education can be improved. He wrote a big thing. And then he was in the midst of his house surgeonship, so he could have been discontinued. And so sir gave it to me. কি লিখেছে? স্যার ও একটু এরকম, একটু কবি টবি, তো ওটাকে দেখো ঠিক করে। তো ঠিক আছে, আই টোল্ড হিম কি ভাই এসব কি করছিস, ঝামেলায় পড়ে যাবি। যাই হোক, সো 3 জন প্র্যাকটিস করতো, ডক্টর বলাই মিত্র, প্রয়াগ মণ্ডল, IS রায়, বাকি গোলকশীল তখন NRS-এ। আমরা যখন MS করছি তখন প্রফেসর শীল NRS-এ চলে গেছে। তো বাকি যারা ছিলেন এক্সিলেন্ট সার্জন, সব কিছুই, ডক্টর বর্ধন, প্রফেসর বর্ধন, অনেকে, they never practiced. So actually practice was not a cult, and সব মানে IS রায়ের কাছে তো সব কিছুই আর কি। স্যার বললো ওই RRC-তে, আমি তখন রেটিনা রিসার্চ ফেলো, এই ইনডিরেক্ট করো তো। তো আমি গেছি, গিয়ে দেখছি কে না, সিদ্ধার্থ শঙ্কর রায়, অন্ধকারে ঢুকে গেছি, তো শুয়ে আছে ভেতরে, তো এই ওপরে তাকান, নিচে তাকান, সব করে করে দেখেছি, তারপরে আলো জ্বলেছে, দেখি বাপরে বাপ, সেম শুয়ে আছে তো এখানে। অ্যান্ড ডক্টর IS রায় এগুলি ইন্টেনশনালি করতেন। হি ওয়ান্টেড দ্যাট, আমরা রায় অপেরা বলতাম, মানে হি ওয়ান্টেড মি টু এক্সপিরিয়েন্স দ্যাট শক। সো হি নিউ কি উনি CM ভেতরে রয়েছে, তো সবাই তো জানবে না, তো গেছেও, আমি আই ডিডন্ট নো। সো হি জাস্ট আউট অফ দ্য ওয়ে, যাও আইও করো। সো দিস কাইন্ড অফ ফান স্টোরিজ ওয়েন্ট অন, বাট হি ওয়াজ আ ওয়ান্ডারফুল পার্সন, লট টু লার্ন ফ্রম হিম। তো এরপরে যেটা বলতে চাইছিলাম, টু দ্য পয়েন্ট, যে সরকারি চাকরি ওয়াজ দ্য মোস্ট ইম্পর্টেন্ট থিং, অ্যান্ড দ্যাট ওয়াজ দ্য কনভেনশন। ওটা না পেলে আর কিছু করার নেই, দেয়ার ওয়াজ নাথিং আউটসাইড। তো আমাদের সময় হোয়াট অ্যাকচুয়ালি ওয়েন্ট রং ইজ 4-5টা ব্যাচ, বিকজ অফ দি নাক্সাল মুভমেন্ট অ্যান্ড all the backlogs, we came out one after the other. তো যখন আমি ইন্টারভিউ দিতে গেছি, so actually that government job was also quite elusive, and I didn't know that, but anyway I was called in. So by that time I had a severe, I became sincerely an ophthalmologist, courtesy amar teachers. So when I went inside the room, একজন ছিলেন যিনি ইন্টারভিউ নিচ্ছিলেন, তো উনি আমাকে বললেন যে না না আমাদের তো টিউবেকটমি করতে হবে, ভ্যাসেকটমি করতে হবে, এরকম ডক্টরস লাগবে, মানে তুমি তো এমএস অপথ্যালমোলজি করছো। তো I felt so bad. I said ki acha madam can I come in? তো ডক্টর আরোরা আমাকে চিনতেন, তো উনি বলে হ্যাঁ হ্যাঁ প্লিজ কাম ইন। তো বলে আমাকে অন্য কথা ডাইভার্ট করছে যে এই ফ্র্যাকচার ক্লেভিকেল ম্যানেজমেন্ট বলো। বাট আই ইনসিস্টেড অন হার। আচ্ছা ম্যাডাম I had given my CV and it had that I was doing my MS ophthalmology. So, I mean, if this was a criteria for recruitment, why at all did you call me? I kind of argued. I mean, your time is important. My time is also little important. Then she looked up and said, then again I said, Madam, that I have done MS ophthalmology. I love ophthalmology. I want to practice ophthalmology. I want to practice ophthalmology to the government area. What are the options? Are there any other options rather than being a GDMO? This was a general duty medical officer. No, she said no. I mean, you have to go this route only. I said, okay. So, তখন আবার ডক্টর আরোরা হি ডাইভার্টেড। অতগুলি কথা বলার পর ইভেনচুয়ালি যেটা হয় না, চাকরিটা পাইনি। সো দ্যাট ওয়াজ দ্য গেম, বিকজ সি লাইক তখন চাকরি পেলে তো চাকরিতেই ঢুকে দিতাম, চাকরি যেরকম চলতো সেরকমই চলতো। হয়তো আবার কাউকে কিছু বলে দিলে অন্যরকম হতো, বাট you know, at some time, you know, calling a spade matters. So, এরপরে কি হলো, এরপরে তো এমএস হয়ে গেল, কিছু কাজ নেই, কি করব, ওই রেটনা রিসার্চ ফেলোশিপ আয়েস রায় উনি বললেন, প্রফেসর আয়েস রায়, যে এটা করো। মানে আমাকে বলনি কেন তুমি ইন্টারভিউ দিতে গেছো? তাই আমি বললাম যে ঠিক আছে। তো I started designing a very new eye center which was coming up with তখনকার দিনের retinal laser, ওই তখনকার দিনে it would be water cooled lasers. So কোথা থেকে pipeline আসবে, কি আসবে, so I had long conversations with Chandan Abraham. I came to know all of them and they would help me out, and then I bargained with every company and changed the design. কজন কনসালটেন্ট হবে, তার জন্য ওয়েটিং কতটা লাগবে, অ্যান্ড অল দ্যাট করে টোরে when the D-Day came কি ওই সেন্টারটা ইনগ্রেশন হবে, সো দ্য লিস্ট দ্যাট আই এক্সপেক্টেড কি I did that free of cost for 6, 7, 8 months. So yeah, I will also practice here as a consultant. So সব city big wigs had come. তো ওদের মধ্যে কিছু কথাবার্তা হয়েছে। দেন আমাকে একজন এসে বলল যে তোমাকে ভেতরে ডাকছে, অ্যান্ড বিকজ ইউ উইল ফেস অল দিস। সো আমাকে বলল যে ইউ ক্যান জয়েন অ্যাজ অ্যান আরএমও। আইএ আরএমও এখানে, দিস ইজ আ ডে কেয়ার সেন্টার, কি করবো আমি? এনিওয়ে আই জাস্ট রেজিস্টার্ড টু মি, বাট হোয়াট আই ফেল্ট ব্যাড that so many gray hairs did not try to include me in the bracket that you said. So immediately, I don't know why, I told, see sir, no, then Mr. Ghoshal actually, who নামটা বলে ফেললাম, যাই হোক যার ওই পুরো ব্যাপারটা ছিল, he just, you know, ব্যাপারটাকে হালকা করার জন্য, না না তুমি করবে, আমি ওরকম নয় এই সেই। তো আনলাম যে না স্যার আমি বুঝে গেছি ব্যাপারটা। তা আমি আপনাকে বলতে চাই যে আমি তো এটা পুরো করলাম, তো মানে ডান ইট, ইজ দ্য জব ওয়েল ডান। তো হচ্ছে তো আমি এই কাজটা শিখে গেছি, তো সামডে আই উইল হ্যাভ আ বিগার প্লেস দেন দিস, ডোন্ট ওয়ারি। like, see, what happens is, that's why I said, like, it's, everything is by default, nothing is by design. 6 months ago, I was mad to get that was the only way out, to get a government job. And 6 months later, I had already promised myself an eye hospital. Now what? Now you get out, তখনকার দিনে, you know, the hard work was, ওই যেমন প্রদীপ মহান্ত has told you, ki রানাঘাটের চশমার দোকান. So spectacle shops were the only place of practice. So, okhane, like, you have various experiences, but, you know, you need to go through them. I don't know, probably you'll never go through them, but those are, একজন এসছে এরকম পেশেন্ট, এসে এরকম বসে পা দোলাচ্ছে, পা দেখাতে এসছে, হ্যাঁ, অবভিয়াসলি ওরকম করতেই পারে, কারণ আমার পাটা একটু দেখে দিন তো, আমি তো পাট দেখারই ডাক্তার, রেটনোস্কোপি করে গ্লোটা একটু কিরকম আছে, সো আই সেড গিয়ে তো রেটনোস্কোপি করে লাভ নেই, অপথ্যালমোস্কোপ নিয়ে ভেতরে দেখছিলাম, তো ইলস ডিজিজ, নিচে একটু ব্লাড ট্রিকল করেছে, না না সেটা তো ঠিক আছে, ওটা ওদেরকে বলছি, ও সম্বন্ধে 2-3টে কথা বলবো, তো আমি ওটা দেখেই, আর there were few laser marks. So I said, and the only person to do laser at that time was Chandan Abraham. তো আনলাম চন্দনের কাছে কবে গিয়েছিলেন, ও তো এর পা দোলাচ্ছিল তো, ফট করে পাটা নেমে গেল। I just didn't tell him anything. চন্দনের কাছে কবে গিয়েছিলেন, না মানে আপনাকে আবার যেতে হবে, আরও লেজার লাগবে। And then, you know, this guy kept on coming to me, এই patient পাঠাচ্ছে, ওই patient পাঠাচ্ছে, and all that. So, like, you have to work these 3 things out in life. So, the দিশা হওয়ার ব্যাপারে যেটা হয়েছিল, that obviously I was one of the very few people, আমি, অরূপ চক্রবর্তী, আমরা we were the next generation, প্রথমে ডক্টর বক্সি, ডক্টর পাওয়া IOL করতেন, আর কেউ না। তখন শেখার ব্যাপারটা হতো যে স্যারকে বলছি, স্যারের পাশে দাঁড়িয়ে থাকতাম, ও ডক্টর পাওয়ার কাছে গেছি, সরি হি ইজ নট নো মোর দেয়ার, সো মেবি উই ক্যান টক, because he is not very close to the ophthalmic fraternity otherwise. I waited for the whole day. He didn't meet me. He came, he walked out in front of me. I told his receptionist almost 10 times, I would just like to meet sir. He didn't meet me. Anyway, তারপরে বক্সি সাহেবের কাছে গেলাম, স্যারের কাছে, তো I he welcomed me into the theatre. I went to his theatre. Those days he used to do almost 30 ECC PCIs a day, all elites, top elites. Each surgery cost was around 30,000 rupees. Yeah, 30,000 taka. So 9 lakhs every day. That was Pradeep Bokshi, yes. তো ওরকম স্যারকে আর শুধু গেলেই বলতো, আর কতদিন দাঁড়িয়ে দাঁড়িয়ে দেখবি, এবার নাম। বাট আই ডিডন্ট হ্যাভ দ্য মানি টু বাই আ মাইক্রোস্কোপ অ্যাকচুয়ালি, মাইক্রোস্কোপ তো কিনতে হবে। সো ইজ অ্যাকিউমুলেটিং মানি। তো তারপরে যখন মাইক্রোস্কোপ কেনা হলো, বাড়িতে ক্লিনিক শুরু করা হলো, তো তখন আপার হ্যাপটিকটা with the Appa Swami microscope, they charged us 30,000 rupees. They gave 30 lenses free. 30 lenses were very costly at that time. 300 টাকা করে ওই multi-piece lensগুলি হতো. And so 9,000 rupees. But that was given free. So I used to work in a municipal hospital. এমনি দেখতে যেতাম, voluntary service. So ওখান থেকে 30টা পেশেন্ট এনে I implanted those lenses into their eyes free of cost, but it was a learning process for me. So this is how you learn surgeries. সো এমনি তো ইন্ট্রাক্যাপসুলার তো করছিলামই, রোজই করছি, কিন্তু এক্সট্রা ক্যাপসুলার দ্যাটস অ্যানাদার বল গেম। সো অ্যান্ড তখন না ওই মানে দ্য কোয়াক্সিয়াল থিং ওয়াজ নট দেয়ার, ইট ওয়াজ জাস্ট আ ইন্ডাস্ট্রিয়াল মাইক্রোস্কোপ। নিকনের ইন্ডাস্ট্রিয়াল মাইক্রোস্কোপ ছিল। Later, after 2 years, they bought and put a cup which had a mirror which made the light coaxial, so you could see the red glow. Tar age mane it was like doing andaje, it was just magnification only, it's just like a loop with some illumination in it. But anyway, saro oiguni diyei korto, Dr. Bokshio oi diye korten, but he got used to it. তো আপার হ্যাপটিকটা ঢোকাতে অসুবিধা হচ্ছে, তো স্যারকে বলেন স্যার আই এম হ্যাভিং প্রবলেমস উইথ দিস। সে এক কাজ কর, তুই মাইক্রোস্কোপ দিয়ে দেখ, আমি খালি চোখে করছি। সো দ্যাট ইজ দ্য কাইন্ড অফ মেন্টরশিপ উই এনজয়েড অলসো। সো এরকমভাবে উই ডিড ইট লাইক ইয়েস, আই মিন তখন ওই যে একটু চশমাটা দেখে দিন তো, all this hits you, like you feel bad and you feel why are patients going to, we don't have anything. So the moment, and see, I told him Ranaghat is a good place. And of course he has this wonderful place which is, he has almost converted it into a temple because he teaches. See, everybody of us have YouTube. We didn't, he did. So through his videos, these young people learn, right? Ajge, he was so courteous to say, Je Paragda helped him to win member scientific committee. Of course Paragda helped. But that is not, I have been the president of the society. I know what elections are. You didn't win because of that. You won because you were a teacher. That is how you got the votes of these young people, and that is how you won. So, opportunities everybody get, but how you use your opportunity is what. So, because my house was in Barakpur, so I started in Barakpur. I asked him to come to Ranaghat because he's from the son of the soil. He picked up a place, see, next to the railway line. So all the patients coming will visibly see NETRAJYOTI. This is very important. You can't advertise in medical profession, advertising is a bad word. O koreche, o chonga phukto. Chonga phoka jano? Chonga phoka dekhte parbe. একটা মাইক নিয়ে বলবে, ডক্টর প্রদীপ মহান্ত শঙ্কর নেত্রালয়ের ডাক্তার আমাদের রানাঘাটে এসেছেন, এরকম করে বলবে, উনি ওখানে এরকম জায়গায় বসেন। সো দিস ইজ হাউ ইউ হ্যাভ টু ক্যাম্পেন। ইট মাইট see his evolution of communication. He started with that communication, and today what is his communication with his patients? YouTube. That's how he talks to his patients and his peers and his mentors and his students. So when we got this scope of, আমার প্র্যাকটিস বাড়তে বাড়তে এমন একটা জায়গায় গেছিল that I used to see only cataract patients. That was quite an audacity at that time, maybe in 94-95. আমাকে দেখাতে গেলে চোখে ক্যাটারাক্ট থাকতে হবে, তো বাইরে কাউকে দেখিয়ে আসতে হবে, ক্যাটারাক্টের প্রেসক্রিপশন নিয়ে আসতে হবে, 2 থেকে 3 সপ্তাহ ওয়েটিং, আর তার 2 থেকে 3 সপ্তাহ পর অপারেশন হবে। Because I couldn't do more than 2,500 surgeries, and I had to see about 8,000 patients. So it's you can't handle. Like I used to work from morning 7 o'clock till night 9 o'clock. So now what? And এরা সবাই আসতো, প্রদীপ এসছে, সবাই এসছে, ডক্টর সমর বসাক আসতো, তুষার আসতো, সিনহা আসতো, প্রদীপ ঘোষ আসতো, অনেকে, সুশান্ত মুখার্জি, many of them would come. কেউ প্র্যাকটিস করতো ওখানে, they used to operate when the OT was free. and Tushar, Shamor, etc. Even Pradeep also, যে আমার স্যাক সার্জারি কে করবে, ওরাই করতো না। আমার তো ক্যাটারাক্ট করা ছাড়া এসে গেছে, এখন কেউ স্যাক তো কি করা যাবে, যাও প্রদীপ মহান্তর কাছে যাও, ও করে দেবে। তো these things used to happen, but then how to actually shape it up into a particular course. এখানে দেখো একটা ছোট্ট জিনিস বলি, যে when Shamor and Tushar came and joined me, they were almost regularly, they used to come. Government circumstances were horrible. Horrible মানে Shamor কাজ ছাড়লো যখন ও প্রিন্সিপাল NRS মেডিকেল কলেজে ও পড়াতো, he was a assistant professor or something, lecturer. So he's a very damn good surgeon. তো ওকে মানে জোর করলো যে আমার মাকে অপারেশন করো, মাইক্রোস্কোপটা খারাপ। তো বলছে যে স্যার মাইক্রোস্কোপটা খারাপ, বাল্ব কি জ্বলছে না। তো বলছে না তুমি এমনি খালি চোখে করো, সবাই তো করে। তো সমাবসাক বলছে যে না, মাইক্রোস্কোপ ছাড়া আমি অপারেশন করব না, আইওএল আমি করব না। তো হি হ্যাড আ বিগ ফাইট। তো সেদিন এসে বললো দেবাশিস দা ডান। পরের দিন আনন্দবাজারে খবরটা ওর হয়ে গেছিল, বাট এনিওয়ে, বাট I always talk to the family, because you know it always, in many decisions Pradeep cannot do something which his wife doesn't agree. It cannot happen. So all the girls are smiling. Nah, of course everything that we do in life we have to do it together. So অন্যদের অ্যাপ্রিহেনশনস আমি বুঝতে পারছিলাম হোম ফ্রন্টে, বিকজ some were not doctors. Bosak's wife was a doctor. So the only thing that worked is I said no, I must do some sacrifice. So the thing was what is that I can do? So I said I have a very handsome practice, let's leave it. Because I knew that was the apprehension, that I'm a big fish, they are working as professors in medical college, they have to leave their government job and come and join me, because I wouldn't settle for anything less than that. I want Tushar and Shamor, they were the best guys at that time. So how to get them in? So I said, I'm leaving my practice, you leave your job, we'll work for 10,000 rupees a month. Is it good enough? So that's how it clicked. So they started. And having seen us, the rest followed. Aru, Poyon, Manoj, Bhaskar, Shourab, and all them, one after the other, Bora, Lorno. So this is how Disha was born, and it started. And then it followed. So the rest, maybe some other day, we'll talk. Thank you.
বাংলায় শেষ করেছো, দেবাশিস ভট্টাচার্যকে দিয়ে কথা বলাতে টাইম লিমিট দেয়া যায় না, সেটা আজকে প্রমাণিত হলো। দেবাশিস ভট্টাচার্য কিন্তু প্রদীপ এমন একটা পরিবেশ তৈরি করেছে যে দেবাশিস ভট্টাচার্য নিজেকে পুরো খুলে দিয়েছে, উন্মুক্ত করে দিয়েছে। এমনভাবে দেবাশিস ভট্টাচার্যকে, ও আমার ভাই, আমি কখনো দেখিনি আমার কলেজ লাইফ থেকে। ও ডিফারেন্ট সেশন, অল ইন্ডিয়া সেশন, এভরি সেশন, সব জায়গায় আমি দেবাশিসকে বলতে শুনেছি, কিন্তু কখনো ও এত প্রাণ খুলে ইংলিশ আর বাংলা সব মিলে এমন সুন্দরভাবে বলে গেছে, এটা আমি কখনো দেখিনি। এবং এতই ওপেন হয়ে গেছিল, মনটা ওর খুলে গেছিল, যাতে এসে আমাদের প্রদীপকেও একটু ছোট্ট করে বলতে হলো বড় স্পিকারদের জন্য একটু টাইম অ্যালট করবার জন্য তুমি রেস্ট্রিক্ট করো। দেবাশিস, থ্যাংক ইউ সো মাচ। তোমার এই যে সেন্টিমেন্টাল মোটিভেশনাল টক্স যা জুনিয়রদেরও মোটিভেট করবে, আমি দাদা হিসেবে আমি খুব অ্যাপ্রিশিয়েট করলাম। থ্যাংক ইউ সো মাচ দেবাশিস।
Very helpful person too. You can go to him for any help.
So, because of we are running late, we are having Dr. Devashish Poiragi on management of macular edema. Pen drive nahi? Pen drive?
Point. Afternoon, everyone. Today I will be speaking about the management of diabetic macular edema. First of all, I'd like to thank Dr. Pradeep Mohanto for giving me this opportunity. So, how do we define diabetic macular edema? It is characterized by retinal thickening involving the central part of the macula due to the diabetic complication. And next one is, what is this chart? We have a lot of PGTs here. Can anybody tell what is this chart? What is the name of this chart? Any PGT from? This is actually ETDRS grid, and it has 3 circles, one the inner, then intermediate, and the outer circle. And this one is the 1 millimeter diameter, second one is 3 millimeter, and third one is the 6 millimeter diameter. And the central 1 millimeter diameter is called the central subfield thickness, and this is very, very important because all the clinical trials has taken this central subfield thickness as an important parameter while treating with anti-VEGF therapy. Yeah. So, sorry for the interruption. So, you have to remember this macular thickness map, which is there with all the OCT medicines currently available. And while reading in the OCT in patient with diabetic macular edema, you have to actually look at this macular grid and see the thickness of the central fovea to decide about the treatment of diabetic retinopathy. So currently we have approximately 77 million people in our country suffering from diabetes, and this number will increase to 125 million by 2045. And approximately 1/3 of this population suffer from diabetic retinopathy, out of which 1/3 has a vision threatening form of retinopathy that includes DME and PDR. So you can imagine the magnitude of the problem that we are facing. So what is the pathophysiology of diabetic macular edema? There is hyperglycemia induced upregulation of many biochemical and molecular pathways like polyol, AGE, PKC and hexosamine, And as a result of hypoxia and inflammation, there is release of vasoproliferative substances like VEGF, angiopoietin 2, and many others. So as a result of these substances, we have breakdown of the blood-retinal barrier, and there is increased vascular permeability, leading to accumulation of fluid first at the level of the outer plexum layer and inner nuclear layer, and ultimately it spreads throughout the neurosensory retina, leading to diabetic macular edema. So before the advent of OCT, we used to follow this ETDRS guideline, and we used to define the clinically significant macular edema according to ETDRS guideline, and we had 3 criteria for that. And we used to treat them with grid laser photocoagulation, and we had 50% reduction of moderate visual loss with laser photocoagulation, and less than 3% of the patient actually showed improvement in visual acuity. And to our surprise, many of patients showed worsening of the macular edema and reduction of visual acuity despite grid laser photocoagulation. After the invention of OCT, we have reclassified diabetic macular edema, and we have seen several presentations, OCT presentations of diabetic macular edema, like localized thickening, spongy thickening, cystoid macular edema, serous retinal detachment, vitreomacular traction, taut posterior hyaloid, and epiretinal membrane. So diabetic maculopathy is again reclassified as based on the OCT presentation as tractional, which includes vitreomacular traction, taut posterior hyaloid, and epiretinal membrane, and non-tractional as spongiform edema, cystoid macular edema, and neurosensory detachment. So again, the non-tractional diabetic macular edema is reclassified as center involving diabetic macular edema and non-center involving macular edema. And based on this OCT presentation, we have different treatment guidelines. For center involving diabetic macular edema is most commonly treated with anti-VEGF or steroid, whereas non-center involving diabetic macular edema is treated with focal laser. And this is the only indication of laser photocoagulation in diabetic macular edema. So coming to the OCT presentations here, out of these 6 images, only this condition requires laser photocoagulation nowadays, and the cystoid macular edema, spongiform thickening, and serous detachment, we have to go for anti-VEGF therapy, and taut posterior hyaloid, vitreomacular traction, and epiretinal membrane, they require vitreoretinal surgery. So these are the images of non-center involving diabetic macular edema. Here we can see there is a sustained ring away from the central fovea, and usually we get a leaking microaneurysm at the center of the sustained ring. And this is the OCT image which shows the intact central fovea, and the macular thickness map also shows normal fovea in the center of the fovea. Whereas with center involving diabetic macular edema, here we can see there is a significant increase in the thickness of the central fovea, which we can see with the 3D image, as well as which is present in the central subfield area of the ETDRS grid. So these patients will require anti-VEGF therapy. So coming to the examination part, how do we detect diabetic macular edema? Cilium biomicroscopy using 90 or 78 diopter is the best way to detect macular edema clinically, because we get stereoscopic view, and OCT is the most commonly performed investigation in ophthalmology also, and it is very, very important tool to detect diabetic macular edema. And it gives us a high resolution cross-sectional image of the different retinal layers. Currently we have 2 different types of OCT, spectral domain and swept source, out of which swept source is the best one because it has a greater wavelength and deeper penetration to the tissue, and we can image up to the choroid. And we have several OCT biomarkers which actually help in determining the treatment of diabetic macular edema. So out of which I'll go through a few OCT biomarker images like the bridging retinal process, pearl necklace. Here we can see the presence of hyperreflective dots along the wall of the cystic space. They indicate the longer duration of the disease. And there are other OCT biomarkers like disorganization of the retinal inner layers here, which indicate the macular ischemia, foveal hard X-rate with cholesterol crystal and hyperreflective crystalline deposits, and disruption of the external limiting membrane and ellipsoid zone. These three OCT biomarkers represent very poor visual outcome despite treatment with anti-VEGF therapy. And there is another OCT biomarker where we have the hyperreflective dots, which is present all over the neurosensory retina, and it indicates the inflammatory pathology of diabetic macular edema. And in these cases, we have to treat this situation with intravitreal injection of steroid. Currently, we do not perform fluorescent angiography routinely for all diabetic macular edema, but it is indicated in case of refractory diabetic macular edema where we get suboptimal response, in case of unexplained vision loss where we are suspecting macular ischemia, and before contemplating laser photocoagulation, and also when we suspect proliferative retinopathy to detect NBE or NBD. OCT angiography is again another important diagnostic tool, and which is non-invasive, and it gives us images of different vascular plexus of the retina, which we never used to see with normal fluorescent angiography. And here we can actually get the detail of the retinal microvascular structure, and we can actually quantify the foveal avascular zone, we can measure the foveal avascular zone, and we can also assess the vascular density of superficial as well as deep vascular plexus. So this is the OCT angiography of the central fovea, and this OCT angiography can also detect the microvascular changes before the appearance of clinical diabetic retinopathy changes like microaneurysm or other vascular abnormalities. So we can actually ask the patient to go for strict control of blood sugar and other parameters if we get these things, and we need to follow them up at regularly. And presence of microaneurysms at the level of the deep vascular plexus and enlargement of the foveal avascular zone, they are associated with refractory diabetic macular edema. They are the poor responder.
It's excellent talk about diabetic macular edema for the juniors as well as for seniors also. It's a beautiful, nice pictures, excellent OCT, very nice. And like, we want to have, anybody wants to have any question? Any doubt about the EDTRS? Something he mentioned about that. Anybody wants to say something or ask something to him? It's a very important word. Any question you want to ask to the Acha, okay, no, now it has come. Okay.
Coming to the management part, here we have to have a holistic approach while treating diabetic macular edema because it is a multifactorial disease. And not only we have to have a very good glycemic control, but also we have to control blood pressure, dyslipidemia, we have to correct anemia, nephropathy, and sleep apnea is also again very important. It worsens diabetic retinopathy. Apart from that, we have to change the lifestyle, like we have to go for regular exercise, we have to have a diet control, and we have to stop smoking. And again, we have to take the history of the medication of anti-diabetic medications, particularly glitazones like pioglitazone or rosiglitazone, because they are associated with worsening of the diabetic macular edema. So you have to consult the diabetologist to avoid these glitazones while treating diabetic macular edema. The mainstay of treatment nowadays for center involving diabetic macular edema is anti-VEGF, the first line therapy, and DSCR.NET protocol I study, which is the first phase 3 trial, which showed that ranibizumab was better than laser photocoagulation for center involving diabetic macular edema. We have several landmark studies. I'm not going in details to that, but DSCR.NET protocol T, which showed that if the visual acuity is more than 6/50, there is not much difference between the different anti-VEGF agents like aflibercept, ranibizumab, or bevacizumab. They are also almost equally effective. But if the visual acuity is less than 6/15, aflibercept scored better than bevacizumab, and to some extent better than ranibizumab. So aflibercept should be the drug of choice if the visual acuity is less than 6/15. So here we have all the anti-VEGF agents currently available, starting with ranibizumab, because the first anti-VEGF that we got was the pegaptan sodium, but that is not currently available. But ranibizumab is the first line of therapy nowadays, and we have other anti-VEGF agents like aflibercept, bevacizumab, brolucizumab, and faricimab. And out of which the smallest molecule is the brolucizumab. It has better tissue penetration and better drying effect, but because of the intraocular inflammation, we do not keep it as a first line therapy. We keep it as a reserve. If other anti-VEGFs do not work, then we use that. And out of which two anti-VEGFs like aflibercept and faricimab, aflibercept has additional inhibitory effect in placental growth factor, and faricimab is a new kid, and it has dual inhibitory effect. It is humanized bispecific monoclonal antibody. It blocks both VEGF-A and angiopoietin T2. And the most important part of the faricimab is it causes microvascular stabilization. So there is remodeling of the microvasculature, and which is very, very important for diabetic patients. So how do we schedule our dosing? So in diabetic patients, we give monthly injection. Usually it is 3 to 4 monthly injection or till the macula becomes dry. Followed by as and when required or treat and extend protocol. And exception is brolucizumab. Here we start with PRN dosing from the beginning due to high incidence of intraocular inflammation. And when do we stop anti-VEGF treatment? If there is less than 10% decrease in central subfield thickness or less than 1 line improvement in visual acuity on a lens chart. And when do we call it non-responder? If the macular edema persists and visual acuity is less than 6/12, despite monthly injection, we call them non-responders. So in such cases, we have to switch to other agents. That's why we start with the conventional anti-VEGF like ranibizumab, and after that we switch to higher agents like aflibercept, faricimab, or brolucizumab, and that is the preferred anti-VEGF for phakic eyes. But for pseudophakic eyes, we can straight away switch to intravitreal steroid, that is Ojudex. So what are the indications of intravitreal steroid implant? First one is the refractory DME or pseudophakic patients, persistent edema, and patient required cataract surgery, and it can be used as a first line therapy in patients with myocardial infarction or recent cardiovascular events, or presence of extensive foveal hard exudates with hyperreflective dots on OCT, and in post-vitrectomized eye because anti-VEGF get washed away very fast. So intravitreal steroid has longer duration of effect, like 4 to 6 months duration, so you need to inject once or twice in a year. So indication of laser photocoagulation, as I said, it is indicated in non-center involving diabetic macular edema, and here you have to target the microaneurysms which are present at the center of the succinator ring. And second indication is center involving diabetic macular edema after treating with anti-VEGF. We have non-center elements, so we have to need to treat them with laser photocoagulation. And if a switch to steroid is not possible, in case of refractory diabetic macular edema, like in patients with glaucoma or young phakic patients, because chance of rise of IOP and cataract is very high. Nowadays, many centers have micropulse or subthreshold laser. It causes less damage to RP and outer retina, and it has equal effect also. And the studies have shown that scatter laser to peripheral non-purpose retina on ultra-wide field fluorescent angiography does not improve vision in patients with diabetic macular edema. So this image shows the improvement following focal laser photocoagulation in patients with diabetic macular edema. And indication of vitrectomy is limited to recalcitrant DME, vitreomacular traction, epiretinal membrane, and taut posterior hyaloid. It causes better oxygenation to inner retina, and there is improvement of retinal thickening. And we have this table which is very, very important, and it is given by AI-based Diabetic Retinopathy Task Force and BRSI. And if we have DME and there is no edema, so we can easily observe them. We can call the patient for frequent follow-ups. If there is non-center involving edema, we can have very close follow-up or we can do focal laser to the microaneurysms. And if there is center involving diabetic macular edema and if the visual acuity is quite good, like 6.6 or 6.9, we can observe them, and but we need regular follow-ups. And if the visual acuity is less than 6.6 or less than 6.9, then we have to go for anti-VEGF injection, intravitreal anti-VEGF. And if we have CIDME with proliferative diabetic retinopathy, we have to treat the patient with intravitreal anti-VEGF followed by laser photocoagulation. In patients with pseudophakia, we can give intravitreal steroid or intravitreal anti-VEGF. In patients undergoing cataract surgery, it is preferable to treat the macular edema 2 weeks before the cataract surgery with intravitreal anti-VEGF, or you can also inject intravitreal anti-VEGF or steroid during surgery, cataract surgery also. In patients with glaucoma, intravitreal steroids should be avoided. In patients with lattice degeneration, we have to treat the lattice degeneration with prophylactic laser before intravitreal anti-VEGF injection. And in post-vitrectomized eye, intravitreal steroid is preferred over intravitreal anti-VEGF because of the long-standing effect. And in other coexisting systemic comorbidity, like in uncontrolled diabetes, we have to actually have very good glycemic control along with intravitreal therapy to get optimum result. And in patients with CKD or anemia, it is better to get a clearance from nephropathy, nephrologist. And in pregnancy also we have to avoid intravitreal anti-VEGF. And one more slide. And in patients with macular infarction also we have to avoid intravitreal anti-VEGF. So to conclude, diabetic maculopathy is a very complex disease. Various therapeutic approaches, newer drugs and treatment methods have been developed, and till now 25 to 30% patients are non-responder to anti-VEGF therapy. So the optimal treatment method has still not been achieved. Thank you very much for your patience hearing.
Thank you, Dr. Debashish. Excellent, detailed presentation. I have only one question to you.
Yeah.
What is the, come this side,
Yeah.
until Dr. Suvenda, you get ready. I have a question for him. What is the role of IVTA in current management? Because you talk about Ozurdex, all big things, lot of costly thing. Is there any role of IVTA in current management?
So IVTA, personally, I do not use IVTA because there is a high chance of rise of intraocular pressure. And studies have shown, protocol U, that the IVTA and laser, there is not much difference at 5 years follow-up. So they are almost, the results are almost equal. So personally, I do not use IVTA for a long time. I prefer intravitreal Ozurdex because chance of IP rise is less with IVTA and it has more sustained effect.
See, intraocular pressure rise is not there in all the patients. Only in the steroid responder, intraocular pressure rise is there. number one. Only in steroid responder, intraocular pressure rise is there. High responder is very few, very rarely, and most of the cases, IVTA induced rise in the intraocular pressure can be managed with 1 or 2 with the drug. And it's a very cheap option. If patient cannot, his patients can afford, that's a different issue. My patients can't afford. So if patients cannot afford, that still is a good option. All the patients cannot afford Ozurdex. Yeah, now Suvendra, yes.
Okay. Okay.
Yeah. So
how much do you charge for that? How much? Yeah, you tell first. Here it's open. You charge how?
Hello.
How much you charge?
On small announcement, after this presentation, the speakers, PGT session speakers and delegates, they will get the prizes and speakers participation prize from our present AIS President, Dr. Partha Biswas. So please be here. And now let me say just a few words. B-Hex and B-Octa we know are very good devices. We use them. We don't know how much effort has been there to make these devices. So we have the inventor of these devices, B-Hex and B-Octa. We are going to listen from him how much effort and how much sleepless nights he had to spend to make these devices.
Thank you, Pradeepda, for this opportunity, and I am between you and lunch, so I'll try to make this interesting and worth the wait. Excuse me, I won't start if you don't stop. Yeah, take it. I'm coming to it. This is part of the deal. Okay, so an inch of nylon is my story of the last 18 years, the journey from an idea to B-Hex and B-Octa. So the B-Hex is an invention which has made small people surgery easier for surgeons, safer for the patients, and affordable for healthcare systems, and with very frugal resources. I dedicate this to my tinkering, nothing is impossible dad, my forgiving mother, my caring, encouraging, loving, and tolerant wife, and of course, my deprived and yet loving children. Okay, and I thank you all, Devashishda, Partho, Pradeepda, Shugoto, all of you have been great help in this journey, my team at MedInvent Devices. There are some interesting chapters in this book as you go. This is just a virtual book, e-reader for you. So the ones in the red are really interesting, the sinning doctor and the wolf in sheep's clothing. So let's see how it goes. So I, like every other kid, was very curious. Only thing is I was a little bit daringly curious, so I would open up the radio to see who's talking from inside. And I was satisfied when I saw those 2 miniature valve tubes. You guys have not seen these radios. These are called valve tubes, and I was convinced that one is a miniature man and another is a miniature woman. When my dad was in the defense, so they used to go for parties, dinner parties. I used to have a field time. I used to open up the watches, clocks, everything in the house, render them unrepairable. And my parents were very forgiving. I used to always have that problem, where did these extra screws and parts come from? Never solved them. Now, of course, I'm a full-time, 24/7 in-house plumber, electrician, everything, with better results probably. That's why my wife tolerates me more. So, that spark hasn't died yet. I've been a notebook traveler all my life. I carry a notebook and a pencil every time. I used to love international flights, 15-hour flights, 20-hour flights. I used to keep me very happy. I could draw, I could think, I could do whatever I felt like. But I still wake up in the middle of the night and draw. Still wake up, okay? My wife doesn't like that part. 5 years, 2007 to 2012, I just kept thinking. I needed a pupil expander which will go in through tiny incisions and will be easy to use. That is just a fraction of the notebooks that you'll see. Or every conference, I would dump the bag, I'll pick up the notebook. Okay, that is a big attraction for me. There was a life-changing event in 2012. I had a heart attack, and actually That was my eureka moment. I was lying down in the CCU, that is, it used to be a femoral entry, so I had a sandbag on my, I had a stent, so I had a sandbag on my thigh, and that's when I asked the nurse in the CCU to give me a paper and pen, because I was not traveling, and that's when I realized that the biggest problem with the present devices was the biplanar scrolls. Biplanar scrolls. Rinalda. So, the biplanar scrolls, they would snag the incision on the way in and way out. So the best was to make them uniplanar. If you make it uniplanar, you have solved all the problems. So that was my eureka moment. So now my drawing started making sense. Notches and flanges came into being. That was how I thought that I visualized the device. More diagrams were ready at very rapid pace. I am not a very patient person. And now I thought I should file a patent, and how do I do it? So I approached a few patent agents, and I found them woefully lacking in the enthusiasm. They would sit over it and not do anything, so I became a self-trained patent agent. Okay, so this is a long journey, and there's a stage called Patent Cooperation Treaty. That's when they filed the international patent. Till that, I filed on myself. It was like doing a thesis, and I actually went through a lot of literature and learned the patent language so that I could phrase it that way and filed it. There were some helpful patent people in the patent office. Now, I had a design, but it had to get to the device, and how do I do it? I approached certain manufacturers. They just surrendered and said, the jig is impossible to make. Well, because of the scale. So I approached a plastic manufacturing person, Mr. Maheshwari, and he gave me an idea. He said, do it yourself. Koi nahi karta, aap khud kar lo. Okay, so do it yourself. He said, take a piece of nylon, wind it around a nail and put it in a hot air, in an oven. Kiska oven? Biwi ka oven le lo. Okay. So there it is. The first Bhattacharya ring or the spring was born over there. That was the basis. I was elated when I could do this. So making the jig was a big problem, big challenge, but then small scale is not a problem for ophthalmologists. We have our devices. The APA table mount microscope, my tools, I was already presbyopic, so I needed a microscope very badly. Our standard tools, drills, I had a workshop, so I had tinkering habits. So I tried and tested every possible material, stainless steel, badminton guts, fishing line, name it. I have been to every market, every plastic device or metal device that I could think of. Nothing worked as good as nylon. The good old nylon suture that we use worked. Now at this stage, I was making prototypes, and each design took me 48 hours of intense labor. One design, 48 hours. I had my practice and work, so I bought a professional hot air oven. There are certain settings. That was my first device. It's a 10 millimeter device. It looks ugly. It was dangerous. So it was too big, and that was the beginning of failures. Reject, reject, reject. After 48 hours of working on each, then somehow I managed to make it slightly smaller, but a new problem cropped up. The legs came close together. Now this was a nuisance, so I needed to close the ring. Now with nylon there is a problem. If you look up literature, it says that you need ultrasonic welding to close it. Okay, so I'll keep going as they, thank you. So I needed to close the ring. So ultrasonic welding is very expensive. Okay, so I am a jugadu person. So what do? Home jugad. I tried 5 rupees Fevikwik. Worked. So now that was a changing point, a turning point in my journey. I had a glued joint, and now my rings started looking much better. I started using medical device gauge cyanoacrylate. And after many long hours and failures, I boiled down to 4-0 and 5-0 nylon. These are my first dies actually, which I made, the so-called dies. Now, these are, now I was having, I'm sorry, the slides got mixed up a little. So each of these devices now was taking me 24 hours to make. Not 24, so 1 hour each. At that point, I become more proficient. But the rejection rate was 30%. 30 hours spent, 10 hours wasted. That was, and I was working also. I made 300 handmade pieces, and at this point, actually, I think Partha has heard this part. A lot of people have heard this part. This is a part where I get very emotional, so I'll try to keep it under control. For 2 full years, 6 p.m. I used to return from my clinic on Saturday evening. I would enter my home workshop or lab or whatever you call it. I would come out at 7 a.m. on Monday morning. I used to eat, sleep, drink in that room. It had an attached bathroom. My family would not see me. My wife would just serve me my meals over there, and that's it. My son was 16 years old. He probably had written me off, crazy dad, gone over the hill, bonkers. My wife had to tolerate me. My daughter was 11 years old. She didn't realize why Baba doesn't come out of that room on weekends. That's their holiday from school. So one day I was working intensely on the microscope. I was actually gluing end-to-end Feviquick. It's a very sophisticated technique, crude sophisticated technique. So I used to be intensely. When I finished and I looked up, my daughter was standing with a Ferrero Rocher in her hand. She felt she could woo me with that chocolate. So, sorry, I always get emotional over here. Anyway, so those were 40 nylon rings, and then all the different versions which came, pretty crude looking, but they worked well. And now my rings were looking less ugly. That's the first generation. That was almost 3J0 or something. Then came the second generation, which was 40, which I used for my trials secretly. And then the 50 ones, which looked better, and actually this was my JCRS publication, also has these images. This went out for global key opinion leaders trials in Europe. That time it was easier to send things. And these were good to go, so I used to send them for ETO. So you can see those dates, 2016, and also this is from my museum. So first taste of success comes by way of Colonel Rangachari Award for the overall best paper in All India Ophthalmology Society, and the Sante Vision Award for the best cataract surgery paper. And of course, success leads to success, and it led to the best paper of session at ASCRS, the most read paper in the Journal of Cataract and Refractive Surgery in that year. That it was in July 2014. The what was that? Yeah, BMJ Healthcare Innovation Award, the APACRS Film Festival Award. Do we have an audio connection over here? Audio ache? Audio on rakh minute please. What are the Sorry, I should have told this earlier. Yeah, audio on Ragban. So after the ASCRS meeting, I mean, that's how you get visibility actually. For an Indian to get visibility in the US market or US arena is different. So these were 2 interviews which followed, which were actually...
I'm here with Suvin Bhattacharjee. Suvin, you've created an iris ring. Can I get you to talk about it and talk about how it differs from Mayugan ring?
Yeah, thanks, Josh. We've been struggling with the pupil expander for a very long time.
I'm Dr. Stephen Bold, and I have the great privilege to be with Dr. Bhattacharjee from India. And he has an award-winning paper that he'd like to tell us about. Welcome, Dr. Bhattacharjee. So good to meet you.
Thank you. Pleasure to be here. The unique thing about this ring is that it goes in through a single 20-gauge incision. We require no side ports, and you'll have a well-expanded pupil.
So a 20-gauge incision, and you can put in a ring and expand the pupil, was phenomenal at that point. So within days or weeks, I got an offer from competition. It was quite a lot, handsome offer. But then there are tricks in the trade and games in this thing. What I realized was by reading the MOU that it was basically to acquire the patent and kill it. Okay, that's also a game. But then it was validation of my claim. That was there. So if a guy wants to pay a certain amount of dollars, I won't quote the figure because it never came. But then this success didn't last long. Happiness didn't last long. My patent hit a wall. And what we call in PC patent language, the International Preliminary Report of Patentability, IPRP. It was a bad report, awful report. The examiners did not find any inventive step in my so-called invention. That is a way things move, but patents are country specific, so you can actually still go and file in each country from there on. So I hired lawyers in each country. It was a tall task, and it was actually a high-stakes gamble because I was paying in dollars, I was paying through my nose. And I still had to formulate the whole arguments and give it to the patent attorney in that country, and then he would file it. And my woes continued. It got rejected in every country. India, US, Europe, China, name it. All jurisdictions that I filed, in legal language you call it jurisdictions, it got rejected everywhere. So now the game was difficult. I went into a very dark place. Nobody knows over here. I was continuing with my work, but I was in a very dark place. I started questioning whether there was an unmet need, whether people would actually pay money to buy this. Was I on the right path, or was I just chasing a dream without any reason? People wanted it, apparently, but was it worth commercialization? I was funding it myself, so I was bootstrapping. I was devoting less time to my practice. My earnings were shrinking. So costs were mounting. Patent reports were unfavorable. Was it being worth pursuing? Fortunately enough, I applied for the big grant, and this big grant is actually across all science disciplines. Pure sciences, agriculture, physics, engineering, everything. It's across all sciences. I got a 50 lakh grant, so that was big help at that point in time. And it was a real tough call with all those costs mounting. But ambitious guy I am, so I went ahead and participated in something called the India Innovation Growth Program, IIGP. It's a very, very, it was at that point, it still continues in different forms by Lockheed Martin, FICCI, IUSSTF. These are very big, well-known organizations. So this is again, this had 4 layers. The earlier one had 3 layers of competition. This had 4 layers of competition. And I was fortunate enough to be called, to be chosen as one of the top innovators in the country. So we got a gold medal for that, and a government-sponsored technology commercialization training with Stanford Graduate School of Business, IC Square Institute, University of Texas in Austin, global commercialization support, and a visit to Thai Silicon Valley to see all the unicorn startups. You see, so that was Cisco, Google, Facebook, Instagram, NASA, and these are a few perks of being an innovator. This is in the NASA Ames Center. You can see Google, Instagram, Facebook. I've been all whatever you're using, I've been there. And of course, the courage of my convictions and a great supporting wife, actually. Despite no great granted patents, I had the courage to go in and commercialize. So we decided to launch commercially. So the only criteria I had was it has to be rapid production. It couldn't be handmade like I was doing it then. It had to be rapid production. It had to have a consistent dimension, and there had to be economies of scale. So I needed the correct material and correct technology. Now it begins another journey of failures. And by now I had got used to failures. I used to anticipate them. Okay, the first round is going to be failures, so brace yourself. So 3D printed ones did not have the mechanical strength at that scale. I tried copper beryllium. These are all springy material and spring steel. They were too stiff. That didn't work. But I won't bite the dust, so I will keep on going. And finally, in 2017, we had the 4th generation of the Bhattacharya ring, or the BX, and that was polyimide. That's what you find in your flexible circuits. That is a resiliently flexible material, and you can take temperatures up to 400 degrees C. I shouldn't autoclave your BXs, by the way, but anyway. Don't reuse. You can reuse by ETO, but not autoclaving. So then quickly, within a year, we had different iterations, one with no holes, the mid-flange holes. I think Partho over here has used the no holes, or I think the no holes and the mid-flange holes. One of Partho's videos was very popular, and Partho is a little senior to him, but I call him by first name. He allows me that privilege. We work together, we have assisted each other. And there is sunshine always after rain. 2016 to 2018, my patent was granted in all 16 jurisdictions that I had filed. So India, US, Europe, all over Europe, Canada, Australia, Japan, Korea, China, Singapore, Hong Kong, everywhere. I still hold those patents. My trademark was registered, the BHX trademark is registered globally. Nobody can touch that trademark. And the jewel in the crown was the AIOSP Severity International Award. This is the highest award an Indian ophthalmologist can get, and I've had the great privilege of having that, thanks to AIOS. Debashish was the first person who told me that you are on the right path when I got my Kanal Rangacharya award. He was a judge and he came out and told me quietly, you be prepared. So, and it's very heartening to see that, in 2020 when we conducted a survey, to see that the BHX was neck to neck with iris hooks, while the price of the BHX was 4 times more. That was very heartening to see. We haven't done a survey after that. Now, garnering key opinion leader validation was important before we launched commercially. So I formed a group of, WhatsApp was also, groups were nascent. So we formed a group, and actually it was a self-learning group, and that way the key opinion leaders were kind of, they started using it. There were some early adopters, so that helped us in the journey. I was naive, so I had to learn the ropes of, I had to come from a business background, I'm a Fauji's son. So we had an exclusive distributor who was overpricing, so the rings were priced at 2,995 and the forceps was 14,000. So I actually threatened that guy, and then I said, okay, I'll launch the forceps myself and this and that. So we brought down the prices. Actually, we terminated the exclusivity, down-regulated the prices. We got multiple distributors, and we started selling directly. So I myself started giving, or my company started giving the distributors a run for their money. They had to earn that. They could get their own clientele. So it was a healthy competition, but that's how it spread now. I'm finishing, don't worry. Pretty close. Now, this is something I've struggled with. I have been always looked up as a sinning doctor, and it's unholy to discuss costs at scientific meetings and social platforms. I don't know why. I really have never understood the double standards. A doctor can indulge in share trading and property trading, horse racing. You can do anything else. But when you make your own device and you sell it, it's unsinful. What do you want? You want MNC to take up the device and sell it at twice the price? You want to be happy about that? And of course, there's another side to it, and people perceive in the social media I'm a wolf in sheep's clothing. So I do indulge in carpet bombing. And in all the groups, you've all seen that. And I will just ask you to bear with me, because that saved money in marketing helps you get more affordable devices. So it's your choice, whether you bear with me or not. So learning and teaching has been a very good experience. The whole concept of rigid and elastic pupil had to be propagated and pushed in, and you will see often a video coming up. And that has changed the scenario. If some of you want to join the group, the QR is there, you can join it. I'll be happy to include you in the groups. So, now this is something called in startup language a blue ocean strategy. You exploit an absolutely unexploited market. There were pupil expanders for phaco. There are so many pupil expanders for phaco, none for MSICS. SICS surgeons don't need visibility. You need visibility more than this. So you need for every stage. So we started working hard. Pradeep Mahanta, a lot of people have been, Pradeep has been a huge support. So, you can see it, it's visible. So we did one for SICS. I had one trial, it failed. Been through failures over there also. And then came the expandable XL people expander B-Octa. We have modest exports. We're doing well, okay. He's asking me to close down. Okay. Can you please? So this is just basically showing how many YouTube videos we have. I can hold it up like this if you want to see. I can hold it up like this. No, wait. Okay. So I know this by heart. So this is sorry. So I'm very happy with the number. I don't. Yeah. I'm very happy that surgeons are excited to share their YouTube videos. That means there is still a whole lot of excitement amongst my colleagues, and that's good. That's good because that helps teaching. How are we doing? We are doing very well actually now. This year, if I take year on year, we have actually, our sales have doubled from last year. So that's very good with two new products or new devices. I think for a company like my size, our size is pretty good. Where we're going, we are trying to scale up. It's difficult to scale up sometimes because business alignments are very different. It's a different game. So we're looking for a reasonably good manufacturer distributor whom we can work with, who has global reach, and we get the value of our hard work. The sweat, blood, and time that I've spent in this has to be rewarded. So, and that's not a compromising place for me. What keeps me going is your wonderful small messages that keeps me going always. I'd like to finish this on a very different note. I'm not yet finished. So while we celebrate success, we must be kind to failures too. Remember, it's the failures which have guided us to success. They have shown us, flagged us in the right path. So please be very, very sympathetic to failures. They are the ones who have led to success. Be kind to them. Anyone on your sides who has been a failed innovator, please give them due respect. So this is a group. Anybody wants to join in, I'll be happy to include you. Thank you very much for your kind attention.
Thanks a lot, Suvenda. Small people means B-Hacks and B-Octa. So we know it was not a... Parthoda, now we are going to invite President AIOS, Dr. Partho Biswas. Parthoda, you get ready, and meanwhile, I'll hold on Suvenda. I will say one thing. He has showed the journey. Today we see the finished product. That's what we say, okay, fine, this product is there. But how much hard work was there? How many sleepless nights was there? That's what Suvenda has said.
Thank you. 30 seconds. Pradeep Mohanty সবসময় সেন্টিমেন্টাল, কিন্তু আমরা খুব প্র্যাকটিক্যাল তিনটে মানুষকে জানি, দেবাশিস ভট্টাচার্য, পার্থ বিশ্বাস আর সুবেন ভট্টাচার্য। তাদের সেন্টিমেন্টকে উগড়ে দিয়েছে আজকে প্রোগ্রামে, এটা এর সবচেয়ে আনন্দের ব্যাপার। আর একটি আমার সেন্টিমেন্ট ছোট্ট আছে, আনটোল্ড স্টোরি। এত স্টোরির মধ্যে ওই 15-16 সালে হঠাৎ একটা ফোন পেয়েছিলাম সুবেন ভট্টাচার্যের কাছ থেকে, পরাগদা একটা 27,000-এর চেক দেবে, 2700 বা কোনো ওখানে ভুলে গেছে অ্যামাউন্টটা, একটা চেক দেবে। চেক তো নিশ্চয়ই দেবো, কেন, আমি একটা কাজ আছে, আমার দরকার আছে, রিসার্চ একটা। আমি হ্যাঁ চেক তো দেবোই, না টাকা তোমাকে দিতে হবে না। আমি সে কি, আমি টাকা দেবো, তুমি কাজ করবে, আমি টাকা দেবো না? তো এই ওকে আমি চেকটা দিয়েছিলাম। এখন আমি চাইছি তুমি আমাকে পেনশন দাও।
না, ঘটনাটা হচ্ছে যে বেসিক্যালি I had not no clue of GST laws and things and all. So we showed some sales and we had not paid any GST on that. So suddenly my chartered accountant said, "What have you done?" So I had to show sales. I had to show it was there were a whole lot of people, or Bowmaker, a lot of people. Actually, I just cut out bills and asked them for the address, and I cut out bills. So no money was taken. Probably I sent them a small sample or something. I don't remember also. But একদম এটা মনে থাকবে ওই লিস্টটা। আমার my first 18 I think sales are those dummy sales which are shown over there, and that is how it worked.
এই পাগলটা বলে দিল, বিয়ারটা লিখে দিল, ও বলছে তুমি কেন এসব করছো? তখন আমি পুরো মাঝখানে দুজনকে ঠান্ডা করছি, বিয়ারটা আগে অ্যানাউন্স করে দিয়েছিল।
No, that apart, Biocta was initially meant for SICS only. He's the one who moved it to Phaco. He got a mouthful from me in the night, and within 1 week I was on my knees and apologizing.
Yeah. So now we'll have a Parthoda's talk, and then after that we'll have a prize distribution.
Just 30 seconds. সেদিন ছিল একটা রাত, শঙ্করনাথলে একটা অ্যাপার্টমেন্টে আছি। একটা ছেলে বৃষ্টির মধ্যে সুটকেস টানতে টানতে এসে দরজার কাছে ঢুকলো। সেই হচ্ছে পার্থ, প্রথম দিন ওর সঙ্গে আলাপ, তারপর থেকে আমাদের মধ্যে বন্ধুত্ব, আর আজকে আমরা এক জায়গায় দাঁড়িয়ে আছি। রানাঘাট পার্থর আসার জন্য বিখ্যাত। যখন ও সার্জারি শিখছে তখন আমি সবে ফেকো শিখেছি। সেই আনন্দটা শেয়ার করার জন্য পার্থকে বললাম, পার্থ তুমি কি ফেকো করছো? আমি কিন্তু শুরু করেছি। পার্থ বলে না আমি শুরু করিনি, বলে তাড়াতাড়ি এসো আমার কাছে এসো। সো এখন আমরা পার্থর কিছু কথা শুনবো, তার সঙ্গে এই যে ইয়াংস্টার্স আছে এরা পাস করার পরে কি করবে, অ্যাজ এ IOS প্রেসিডেন্ট ইউ শুড গিভ দেম সাম অ্যাডভাইস। পাস করে কি করবে, কোথায় ফেলোশিপ করবে না প্র্যাকটিস করবে, প্র্যাকটিস করলে দিশার হসপিটালে জয়েন করবে না তোমার হসপিটালে জয়েন করবে, নাকি একা একা প্র্যাকটিস শুরু করবে, কিছু একটু বলো।
very difficult job now.
কিছু একটা, so I'll tell you with কিছু একটা, ঠিক আছে? জীবনটাই কিন্তু কিছু একটা, কেমন? এটাই হচ্ছে জীবন। এবং আজকে তোমরা যা যা শুনেছো, আজ সকাল থেকে দেখেছো যেটা, সেটাই কিন্তু কিছু একটা ভাবে শুরুটাই হচ্ছে বড়, শেষ কোথায় সেটা ওপরওয়ালাই জানেন। কিন্তু শুরু যদি ঠিক করতে পারো তাহলে পথ ঠিক বেরিয়ে যাবে। এবং এখানে সামনের এই রোয়েতে প্রতিজন কিছু একটা ভাবে শুরু করেছে। ডক্টর পারভেজ আলম নূর আই সেন্টার শুরু করেছে ইন কাকিনাড়া। আজকে হিজ সুলতান অফ কাকিনাড়া। বীর দিশা নিয়ারবাই, but he's still Sultan of Kakinada. প্রদীপ মহান্ত শুরু করেছিল রানাঘাটে। প্রথমেতে গিয়েছিল দেবাশিসদার কাছে, দেবাশিসদা তোমাকে জয়েন করতে চাই। দেবাশিসদা বলেছিল ফিরে যাও রানাঘাটে, ওখানেই শুরু করো নেত্রজ্যোতি। কারেক্ট? শুরু করেছে নেত্রজ্যোতি, এবং আজকে নেত্রজ্যোতি যেখান থেকে শুরু করেছে সেইখান থেকে বেরিয়ে আজকে সারা বিশ্বে নেত্রজ্যোতি বিশালভাবে ভার্চুয়াল ওয়ার্ল্ডেতে নেত্রজ্যোতি কোথায় চলে গেছে, ক্যাট্রাক্ট কোচকেও ছাড়িয়ে গেছে। হু ইজ ক্যাট্রাক্ট কোচ? কারেক্ট। Similarly, Dr. Pankaj Rupalia, one of the finest surgeons, both cataract, glaucoma, and one of the finest teachers. He is actually now a teacher of teachers. He's taught Dr. Love Kochkave how to do phaco. I wish I was with him to learn phaco also. Today he has an institution, he started it, he has a huge number of people following him, and he still teaches. He's one person with that phenomenal ability to do cataract, both hands, right and left. So, Shobboshachi of cataract surgery. Shubhan Bhattacharya, you know, when he was telling this story of his, I was following, I was here, I was here, I was there, I was there. কিন্তু এই যে পুরো জার্নিটা যেটা বললো সেটা কিন্তু শুরু একটা জায়গায়, সেটা হচ্ছে শুরু একটা স্কুটার এবং একটা বাইক, এসডি বাইকের গল্প, ঠিক আছে? কাওয়াসাকি বাইক। সো একই সাথে আমরা এসেছিলাম কলকাতাতে, both of us from different lands, not Calcuttans, coming into the city of joy, nobody around. Yes, but everybody around also. Yes. So why a scooter and a bike? We didn't have money. We joined Silver Line Eye Hospital together. We didn't have money enough to drive our bikes or scooters. So he used to stay in Jalvayu Bihar, I in Salt Lake. And so I said, Shubhan, let's travel together. So one day on Shubhan's bike, pillion. One day on my Khatara second-hand scooter, pillion. So we saved money. And that's how possibly he invented also to make. So I will always say I'm an integral part of BHEX. You want it or not. And then of course financials must follow also. Devashish Da's story is a history. I'm sure most of us know it, but the kids who don't know it, his story is again a story from failure. A story from failure of a person who wanted to design an eye hospital for a very big group. When that group said that you cannot be a consultant, he said, I'm not going to join this group and I'm going to have my own hospital. So today he has not one, but he has 15 and counting hospitals of ophthalmology and a multi-speciality hospital that is coming up, which will give tekka to that hospital which once refused him as a consultant. So, sheikhanei shuru. Failure is what breeds success. And I too do understand that. Poragda, ekdomই নয়. Poragda is one great person. If you go on to the groups of OSWB, you will find him giving his technique of learning for everybody, right from oculoplasty to short cases and absolutely reality cases which he has managed. He has managed in district towns, hospitals, and he has done the right thing at that right place. So his journey is a journey again of a very, very Bengali ophthalmologist. যিনি গানও গান আবার সেই সুরেতে অপূর্ব অপূর্ব কেসগুলো প্রজেক্ট করেন ওএসডব্লিউবির গ্রুপসেতে। সো প্রদীপকে আমি বলেছিলাম আমি বলবো রিফ্র্যাক্টিভ সার্জারি, কিন্তু মানে রিফ্র্যাক্টিভ সার্জারি আর বলা যাবে না, এইটাই হচ্ছে কিন্তু আসল। এবং এইবার আসি যেটা প্রদীপ আমাকে বলল যে সো পাশ করার পরে কি করবে। যদি পাশ করেছো তো কিছু তো করতেই হবে, there is no way out. If you have passed, you have to. But let me tell you, and this is very serious, why I gave the examples of each one of them. They struggled to make each one a platform, an example for every one of us. And I'm addressing to one of the youngest ophthalmologists, Vikram, who is sitting there, who nearly looks like a PG student as well. So it is, you have today a platter. You have today everything that you could desire. If you want to be an inventor, you have your role model right there. If you want to say, nota pachta, ye ghumobo, chalmuri khavo, Dada is there. Hospitals glow. So wherever you want, you join. If you want that, I would also like to do bulk surgeries, onek kaj korbo, Pankaj is there. He'll give you a job. If you want to come to NETRAJYOTI to get trained in Phaco, it is there. A program is there to which so many international candidates come. So everything is there. But you have to pick, you have to choose, you have to make the right choice. If you want that, you want to do academics and clinics and research, it's there for you. So it is you who will have to choose with a mindset, with your heart and a little of your mind. Don't think of money. Think of what you really want to be 20 years from today. Think who is your role model of these front benches. If you know who is your role model, you will do everything right. Not everybody is meant for research. Not everybody is meant for innovation. Not everybody is meant for clinics. But today you have everything. You have to choose your platter. অনেকগুলো মাথা নড়ছে দেখছি, তো যা বলছি মোটামুটি ঢুকছে কি? ঢুকেছে, অনেকটা ঢুকেছে। Rudro as a teacher, Shogato as one of our colleagues who is taking OSWB forward. All these are so important. You are living in the best of times, best of times. You are rich, absolutely rich, rich to do whatever you wish. So it's your choice, it's your path, you have to do it, and if you put your mind and more of your heart, you will do and you will feel, yeah, I have done it. Thank you very much.
Thanks a lot. Thanks a lot, Parthoda. I'll request Parthoda to stay back here because for our PGT, there was a free paper competition was there. And now time has come to give the award. So now I'll request Parthoda, Devashishda, and Paragda. 3 people to come forward. So first, I'll call Dr. Ayan Bhattacharya. He has got the 3rd prize. Dr. Ayan. Photo, bhalo kore photo tolo. Ha. Yeah. Second, I'll call Dr. Pragya Agrawal. Come forward. Amao chobi lini nebe, amiও আছি। চলো এই লাইট ওখান থেকে এই লাইট কোথা থেকে অফ করে স্ক্রিন তুমি অফ করতে পারবে? এটা অফ করো, স্ক্রিন অফ করতে পারবে না? করতে পারবে না। বাকি আলো জ্বলে দাও, বাকি আলো জ্বলে দাও, বাকি ওই সাইড গুলো জ্বলে দাও। স্ক্রিনটা অফ হবে না, এখানে পিছনে ঘরের মধ্যে বলো না, পিছনে স্ক্রিন অফ হবে। চলে कोई बात नहीं, अब नीचे नीचे बंद हो जाच्छिलो। Now second prize goes to Dr. Pragya Agrawal. Pragya, idhar aao beta. This side. You are the boss now. You got the prize. And now first prize goes to Dr. Shravan Mohanta. Come please. From President itself. Two presidents. One. Huh? Yeah. Now I'll call all other speakers. Dr. Renisa Yasmin, please come. Next is Devjani Das. बेटा मुझसे निकल जाता है, I'm sorry. बेटी बेटा, हाँ ठीक है। Sorry. Next is Dr. Divya Jain. Dr. K. Pranav Sai Raman. Dr. Ark Prabha Mangal. Ark Prabha Mangal. Ark Prabha is not there. Okay. Kunal Dongre. Dr. Jyoti Chandak, please come forward. Jyoti, come. Now, Rishav. Where is Rishav? Oh, you are here only. Okay, come.
Actually, we have to thank Rishabh specially because he has got so many PhDs.
Yes. And he's conducted very well, actually. Yeah. Now, Dr. Ankita Sombia. Dr. Ankita, please come. That I won't reveal. But something is good. Something good. And everybody will like that. Dr. Ankita. Now, Dr. Shreyoshi Mandal. Please come. Shreyoshi, please come. Now I think it's giving thanks, say thanks to everybody. So Dr. Pradeep Da. Rishabh, beta. Yeah. So now I'll request, yeah, Dr. Parthuda wants to say something. Yeah,
You know, whatever I say becomes incomplete because, you know, very quietly sitting there in the corner, and I miss that person, is Devashish Boiragi. So, a very quiet person, but you must go to his second site eye center and you must see the phenomenal work that is going on. 15 DNB students, right? A phenomenal center of teaching and learning. So this is what? So teaching, learning can be anywhere in the world, and you have phenomenal examples right here in this hall.
Yeah.
There's another session on the phakic IOL, please.
Yeah, another session of phakic IOL after. No, Pradeep.
After this, we have phakic IOL hands-on course. So we will, those who are willing, will be inside the OT and see in the OT screen.
So welcome to refractive surgery, and as Devashish always tells that the refractive surgery can be done anywhere. And so we begin with phakic IOLs, and it is an instruction course on phakic IOLs, how to do it. It's very simple. So you just have to understand the basic mechanism, techniques, do's and don'ts, and that's where we can come in and help you.
He's wearing a spectacle. So many of all of you are wearing a spectacle. It's a crutch. I'm wearing a spectacle, isn't it? You think of Donald Trump, think of Barack Obama, think of George Bush, senior, junior. Have you ever seen any American president and the entire administrators, Marco Rubio, whatever? Think of any American person wearing a spectacle. This is one surgery we need to learn, and especially in West Bengal. You know, India does 7 lakh refractive surgeries. In West Bengal, 1500, what? Together. That's all. Out of 4.6 lakh cataracts in West Bengal, we do only 1500 refractive surgeries. And you know, the best way to get about it, I went to Dr. Palakaris, who's one of the inventors of LASIK. In his center, nobody is allowed to wear spectacles. Wow. No staff, you don't get a job if you are wearing a spectacle. So you have to get your refractives done. So that's besides the point. I'm talking of big powers like 4 onwards. I mean, just putting in this phakic IOLs, ICL or IPCLs is such a simple job. I mean, and the thing is, everybody, when you see your patients, the most concerned patient you will get is the parents of a child 10 years old whose power has increased by -2. It was 2, it has become 4. Sir, ki hobe ar to mane ami ki korbo, and the guilt complex, you know, and it's better to attack the mother actually, or the father. He or she thinks, I mean, I am transmitting this bad gene to my child. She's going to suffer, he's going to suffer. So, I mean, better target the parents, and at least at that point, you know, just keep on engaging one conversation that, I mean, don't bother about the numbers. So long the retina and everything is fine, after 18 we'll get it off. This constant messaging has to be through us. It's an easy thing, it can be done anywhere, and please, I mean, enjoy the ICL course today. IPCL, I mean, yes, of course, why not? And mind you, everybody, I think he does about 400-500, 300 at least, maybe ICLs. We do more. Now, he's got all those Smile, and we also have Smile Pros and all that. But then affordable class, that is a easier alternative. And but there's no complications, I'm telling you, no complications. No complications to refractive. And some student to win, amader boys hoye geche, but we can also do. Start.
So Dada, you're going to be there in the course of IPCL today.
and the course will be in the OT in the next building, 4th floor, with Lumira T microscope. Please, all of you have lunch now, and after half an hour we are going to start.